The Committee of the Whole is back in order. Colleagues, we are now entering Chapter 3 under Health. We are now doing Part 1, the Guam Memorial Hospital Authority, and I'll remind the rules of engagement. We have 2 rounds of questions with the panelists. Each senator is allowed 10 minutes for the first line of questioning, excluding panel's responses, and the second round is going to be 5 minutes. If you yield your time, that time is fully transferred to the recipient and cannot be reallocated. Once the 2 rounds of questions are complete, the panelists will be excused. You have until the panels are dismissed to submit any floor amendments which you wish to propose. Amendments submitted after the dismissal will be considered out of order. Third round amendments is for amendments and comments. This round is for speaking on the chapter and offering amendments. Each senator will be allotted 5 minutes. Amendments must be submitted in writing to the clerk at session@guamlegislature.gov. Amendments will be processed in order they were received. Any replacement is considered a new submission. To ensure the accurate processing and timely distribution during this round, all floor amendments must be submitted using the proper floor amendment form. Any amendment not submitted in the proper format will be returned. Amendments will be uploaded to the Google Drive. Bookmarks. Bookmarks must be addressed before the end of the chapter. The requesting senator is responsible for ensuring it is brought up. Once the chapter is closed, the bookmark is retired, addressed or not. Appropriation increases. If you move to increase appropriation, you must state the funding source and explain the impact on both the receiving department or agency and the department or agency being reduced. After the 3rd round, I will declare the chapter having been completed. Sizus Masi for your cooperation. Senators, colleagues, at this time, I'm going to go ahead and have the Guam Memorial Hospital introduce their panel and swear them in. And then we will have OFB to go over the difference of appropriation between the EBR and the legislature. And then I will allow the committee chair to have an opening, and then I will allow for GMH to have an opening before we go to the rounds. So at this time, Sergeant at Arms, first of all, Ms. Lillian, welcome back. And will you please introduce the panel that you've brought along tonight on a beautiful Sunday night to get underway with Guam Memorial Hospital.
Yes, thank you, Senator. Yes, my name is Lillian Posadas. I am the hospital administrator. To my left is our CFO, Chief Financial Officer, Ms. Yuka Echanova. To my right is Dr. Ricardo Eusebio. He is our Chief Medical Officer. And to his right is Jesse Kenya. He is our Personnel Services Administrator. To his right is Jordan Paulun, one of our legal counsel. And to his right is Mr. Zaudi Tagadi. He is our Associate Administrator of Operations. And to his right is Rodalyn Ruardo. She is the Assistant Administrator of Operations. And I think that's it for our team.
Sizus Masi, Ms. Lillian, and to the team, at this time, could you please rise to be sworn in by the Sergeant at Arms? And then you will be considered under oath for the purposes of fiscal discussions. Sergeant, you may proceed.
Please raise your right hand. Under penalty of perjury, do you affirm that any and all information you provide today, whether it be verbally, electronically, and in writing, be the truth, the whole truth, and nothing but the truth? Okay. Mr. Chair, under oath, you may proceed.
Thank you, Sergeant at Arms, and thank you, Team GMH. Mr. Guerrero, Director of OFB, I will now recognize you to give a summary of the difference between the EBR and the Guam Legislature's appropriation level.
Thank you, Chairman. Just to start out, to give an idea how we came out to 26, I'll give you the appropriation from FY25. Total appropriation from the general fund for general operations is 13.6. They also received 24 million from the pharmaceutical fund and an additional 20 million from the FY24 excess revenues for a total of 57.8 million. For the FY26, the GMH requested for 105 million. In the proposed bill of FY26 is 41.9 million, but then you add in the 5.2 million on the miscellaneous appropriation from the FY23 audit, will give you a total of 47.1 million. If you look at the governor's executive budget request, the amount that's reflected there is $53.8 million, which shows a difference between the EBR and what is being proposed in the budget bill of about $6 million.
Thank you very much, Mr. Guerrero. At this time, Senator Sabrina Salas Montanani, Oversight Chair for Health, I'm going to recognize you for an opening statement.
Thank you, Mr. Chair. In anticipation of this budget season, I sat down with a couple of freshman senators because, let's face it, this is our very first budget process, and it is one of the very important and few mandates that we senators have to do. But even as a journalist, the one thing that I realized that always irked me, for the lack of a better word, was I didn't think that the money, or that money was truly being prioritized. I just never did. I always thought that we funded a whole bunch of different programs and we didn't fund what I've always referred to and what this group has referred to as the big four: public safety, healthcare, education, and the economy. These discussions eventually evolved into something called Restructuring Initiative for Fiscal Leadership and Efficiency, or RIFLE. It was a draft plan. It was using a scalpel rather than a chainsaw. We wanted to hit targets that prioritize healthcare, public safety, education, the economy. And when you think about the fact that we have a struggling, almost non-existent hospitality industry, we have schools that we need to be maintained, we have a meth epidemic, and we have a hospital in shambles. I mean, it's almost proven that we were right. RIFLE was not anti-Chamorro. It wasn't targeting anybody's specific oversight. It was looking at every single agency that exists as important, but focusing on what's critical right now. But RIFLE isn't even in this budget. It was a concept and a draft that, for whatever reason, was leaked. We've got people, especially the governor, talking about the new state-of-the-art hospital. I know everybody's haggling about where it should be and whether we need it. I'm going to tell you, I'm excited to see what that's going to look like, because I think the governor sees it and I think we see it. Our people do deserve a state-of-the-art facility. But you know what's completely forgotten is we have a hospital now that still treats patients. Thousands of our residents walk into GMH every year. They are grandmothers, our children, babies, our friends, our family members. And at the end of the day, what do we have? What do we have to show for it? We have a hospital facility that is absolutely amazing medical professionals. Your wife, Angelica, is one of them, Mr. Chair. She works alongside some really fantastic doctors, nurses, and support staff. But one good storm could knock that down. Not only will we not have a hospital, if people are in there, and people are always in there, people can get hurt or worse. I want to take care of this hospital, and I'm sure everyone in this room wants to as well. Is it needed to be managed a little better? We can argue that all day about every single agency. The question is, are we going to prioritize our only public hospital? Even if the state-of-the-art medical facility gets built, say it gets built in Magaʹhågan after lawsuits and haggling and negotiation and a bidding process and then a protest period, we are 7 to 10 ways away from seeing that come to fruition. I also want to acknowledge an internal GMH circular that was recently sent to employees. In it, it was shared that the legislature is currently considering a proposed budget for the upcoming fiscal year that will reduce funding for GMH by nearly 15%. Based on our current operating needs, this reduction can result in a shortfall of $28 million, affecting essential resources, services, staffing levels, and our ability to provide patient care. I want you to know that I hear you. I understand the weight of that message, not just as numbers on a spreadsheet, but as a very real threat to the care that thousands of our families rely on every single day. That is why I've been working closely on amendments with you to address these shortfalls. And I will be introducing one significant amendment in particular, an amendment that finally delivers on a campaign promise made years ago, promises that our people are still waiting to be honored. This is not just about balancing a budget. It is about ensuring that GMH has the resources it needs to keep our people safe, healthy, and cared for. I look forward to engaging in a constructive dialogue with my colleagues, finding common ground and working toward a solution that reflects both fiscal responsibility and our moral obligation to protect patient care. Thank you, Mr. Chair.
Excuse me, Senator, and just so everybody understands, I failed to say this in courtesy to the chair and opening. I yield my time on the floor for the first round to give her that opportunity. Now we go to Ms. Lillian Posadas to make her opening for GMH. Jesus Masi.
Jesus Masi, Senator Sabrina, that was very heartwarming, because I was going to say in my opening statement that perhaps I just need to be abundantly and repeatedly saying that, GMH deals with life and death, and that we are open 24/7. And so I appreciate that you recognize that, because perhaps I thought that maybe in all the heated discussions and the debates with regards to budget for all the other government agencies, maybe GMH was kind of fading away in terms of the priority. But thank you for emphasizing that it is a priority. So thank you. And thank you also, Senators, for inviting us down here to defend and to fight our budget for the hospital. We stand before you today not simply as a collective voice for the Guam Memorial Hospital Authority, but as advocates for the thousands of lives that depend on our hospital every single day. The decisions you make in this session hall will ripple through every department and every patient bed at the hospital. Today, our executive team here are here to urge you with every ounce of conviction and compassion to act decisively, to act boldly and courageously to appropriate GMH with the funding it so desperately needs to fulfill its mission of delivering quality health care to our community. Currently, GMH first faces a $28 million operational gap for the upcoming fiscal year. This is not just a number, as you said, Senator Sabrina. This gap represents overburdened doctors, nurses, and other staff who work double and long shifts because we are continuously challenged to sustain adequate staffing. It represents patients who wait hours or even days to access the care they desperately need, not because our staff aren't willing, but because we lack the resources to open more beds. These millions translate into strained morale, operational inefficiencies, delayed treatments, and the looming possibility of compromised patient care. This is the price of inaction. This legislation and this legislative leadership has the power to save lives. Several proposed amendments provide tangible, necessary solutions that can close this gap and safeguard our hospital's future. These measures are not abstract proposals, they are lifelines for GMH and the community we serve. Take, for example, the pharmaceutical fund. For years, cumulative shortfalls in deposits have left us with an additional $10.9 million in unmet obligations. Yet these funds are critical to ensuring adequate stock of life-saving medications and supplies. We need an amendment that appropriates prior year excess business privilege tax collections to this fund, guaranteeing these dollars go directly to patient care. Can we afford to deny our hospital the very resources needed to save lives? Consider also the funding of the nurse recruitment initiatives. Nurse professionals are the lifeblood of our healthcare system. Right now, staffing shortages are forcing closures of patient beds and creating dangerous overcrowding in our emergency room. A week ago, on August 10, GMHA reported a census of 177 patients with 20 individuals holding in the emergency room, waiting for inpatient beds. The highest numbers the hospital has seen in years. Without funding our staffing level needs, we will lose the ability to expand bed capacity, further exacerbating our community's growing healthcare demands. Then there's the hospital antiquated IT infrastructure and systems. I cannot overstate the urgent need to modernize our systems. Take a moment to imagine what it's like to work in a hospital where outdated IT infrastructure disrupts patient scheduling, delays access to records, and impedes timely care delivery. This is not just an inconvenience, it is outright dangerous, frustrating, and a risk to patient safety. reallocating unused funds from a long-dormant bond repayment plan to address these pressing technological and capital improvement needs is not just logical, it is vital. If we fail to act, the consequences will be severe and far-reaching. Essential healthcare services will falter. Staff burnout will escalate as they struggle under high-risk conditions. Patients, our neighbors, members of our families will face delays in care that can mean the difference between life and death. Our community cannot and should not accept or tolerate or assent for GMH to operate in crisis mode any longer. We also cannot allow the dedicated employees of GMHA to feel undervalued and unheard. We requested an amendment that would grant GMH employees hazardous pay recognizing staff whose roles expose them to intense physical and emotional demands, including infectious diseases that are unknown, as this body has done for mayoral staff and GIPWIC employees. Whether cleaning up biohazards or working under harsh, high-stakes conditions, these individuals deserve fair compensation for their labor and the exposure. This is not only a matter of fairness, but of moral responsibility. Your action today is not just about financial numbers or line items. It is about people, about families, about the very fabric of our community. GMHA is the beating heart of Guam's healthcare system, but we can no longer succeed on hope and determination alone. What we need, what our patients and staff need, is your leadership, your courage, and your commitment to providing the resources that will allow GMHA to survive and to thrive. We fervently ask you to fully fund GMHA, to support amendments that streamline and sustain operations, and to recognize this funding not as an expense, but a necessary action to secure a critical lifeline for our community. This is your opportunity to blow past political promises and take decisive action to ensure that every man, every woman, and every child in this community has access to the care they deserve. Senators, the urgency cannot be more clear. The stakes cannot be higher. The time to act is now. We ask you, on behalf of every patient awaiting care, every nurse struggling through dwindling supplies and long shifts, and every family that counts on GMHA, please find the funds, pass the amendments, and help us with our mission to provide quality patient care for Guam. Thank you. We're here to answer your questions.
Masi, Lillian, and appreciate once again the team being here on a Sunday night. We are trying to meet deadlines, and so we have to get these critical budget hearings for getting the information so we can finalize our budget, and we thank you for bearing with us and being here on a Sunday night. Speaker Blas, kick us off.
Thank you very much, Mr. Chair, and to the staff of Guam Memorial Hospital Authority, thank you very much for being here as well. Ms. Posadas, it is very refreshing to hear a statement and a plea to fix our healthcare industry today and not to worry about what we plan to build in the future. Thank you for that. Along those lines, I need to ask, what are some of the ongoing projects that you have right now to help to improve the healthcare, and whether or not their funding sources are available for those current efforts?
Thank you for that question, Speaker. I can start, and then I can hand it over to Mr. Zaudi and Ms. Rodolin, because they are the guru of our CIPs.
Thank you.
The roof and envelope repair is one of them. The chillers replacement is another one. And so I'm going to go ahead and let Rodolin and Z speak more.
Okay, good afternoon. So for 2025, we did have 54 scheduled CIP projects, 31 of which already been completed. And we're looking after the big projects, actually. It's the HVAC system project, which is the heat, ventilation, air conditioning, as well as the roof and envelope upgrade project. We just had the notice to proceed scheduled for this coming week, so hopefully we'll have that ongoing and get it to completion by next year, early next year, hopefully.
Mr. Chair, excuse me, if you can just ask the panel just to bring the mic closer just so we can hear.
Yes, sir, and thank you, Vice Speaker, for recognizing that.
Thank you, Mr. Chair.
Thank you, team.
Apologies for the interruption.
Okay, so we did have 54, and we divided that into 4 categories. The first one is the GMH SNF HVAC. We have 4 completed out of 11. GMH structural architectural improvements, that's going to be now 3 of 9, soon to be 4 of 9. Medical and other equipment, 19 out of 27 completed. And the last one, GMH IT network, system infrastructure needs, that's 5 completed out of 7. Again, just to emphasize, this is just scratching the surface, so other projects needs to be done in conjunction with all this project in 2026.
Okay, and I guess the second question to that inquiry was, the funding is available to complete those projects?
Not all of them. If you recall, some of these, we started the procurement of these with the intention that we were going to use ARPA funding. And unfortunately, when that didn't come through, we had to look at potentially other sources, including our own collections. And as part of the FY2026 submission, we did include, one moment, let me get to that page. In the FY2026 submission, we did include in here $3 million, excuse me. We requested $29.3 million in the FY2026 for CIP and infrastructure-related projects.
Okay. Of the 29.3 million that you requested for CIP for in FY 2026, how much of that was supposed to have been taken care of by the ARPA funds? First off, how much ARPA funds did you lose?
10 million.
You lost 10 million. So is it safe to say that the 10 million in ARPA is what caused you to, if you had the 10 million, you would only be looking at 19 million as opposed to the 29?
Well,
Simple math, right?
yeah,
Yeah.
yes.
Okay. We need to get that, to that, okay? So that this could have been $10 million that we wouldn't necessarily have to be able to fund because you would have had the ARPA funds to be able to do it.
That is correct.
That is correct. I thought so. Okay. And I know we had this conversation, but for the purpose of this budget discussion, you had everything already all lined up to spend that $10 million in ARPA.
Yes.
It was just pulled from under you without any notification. Let me ask you something. Did you already start the RFP process for any of these projects?
Yes, all of them were started off, again, with the intention that we were going to use ARPA. So all of the RFP was done.
Did you incur any penalties or damages as a result of having to pull out of a contractual agreement? Did you have any contractual agreements already all set in place?
Yes, there were contractual agreements for these, and because of the critical need of all of these projects, we actually did not cancel any of them. What we instead tried to do was creatively try to look to see if we have other funding sources to fund, and of course, recognizing that we don't. And so what we did was, for some of them, we delayed the notice to proceed. So then that way, technically, it's obligated, but because we did not have the funding source, but we also recognized that the projects were still important, so we just delayed the notice to proceed until a funding source is available.
But you effectively had to then divert $10 million of already monies that you had placed for other critical needs within the hospital to be able to ensure that you were not contractually deficient, defaulting on
Yes.
this. Is that the case?
Yes.
Wow. Mr. Chair, I think that's about all I need to hear right now from them. Thank you very much. Thank you very much.
Jesus Masi, Mr. Speaker. Mr. Senator Gumatautau, you're recognized.
Yes, thank you, Mr. Chair, and thank you, Jim H., for being with us this afternoon. I don't have very many questions. I'm trying to process what I've just heard here today, and again, thank you all for being here. And I was at the public hearing for your budget, and I think those that might have missed, I think they missed a lot, because I don't want to have to rehash the entirety of those that amount of time with you. But since I got to the branch, and I think I've stressed that on a bunch of different occasions with everyone here, especially at this table, that much of the work that we are going to do won't always be about money, it's going to be about policy. And I think that what we're going to see probably over the next session relative to support of GMH, I think that that's going to be a bit different than what we've seen in the past. I want to just thank OFB real quickly, if I can, and the breakdown of the budget, especially with GMH, because it's very telling. And I want to, again, kudos to Steve and your team, again, talking specifically about the gulf between the submission of the executive budget and what was prepared by the committee. And I just want to say again, for the record, that I appreciate that effort today. I want to say, if I can, that this budget might be a little bit different than what you've ever seen in the past, at least in terms of what you can expect from us, is simply this, is that the committee is going to submit and do its part, give you what you need, but we're going to be really asking a lot of you, because quite frankly, I think the committee chair on finance is pretty much there every day. And so if you say you're going to commit to a project, I'm hoping that you're going to, once this budget's passed, you cannot sit back. You have to lean forward, and you're going to have to give it 110%, more than you've ever had, because he really is the linchpin. And he's going to watch it every day for the next 12 months. So everything you say here, you're sworn in, all those things, but it means absolutely nothing if you're not able to perform. And I just want to kind of give a little bit of a cautionary tale. Policy, I just want to go back, Lillian. So you mentioned the hazardous pay. And if I can, when you think about, if we change the policy here, it's urgent. We can do it, I believe we can. When we think about the cost, have you guys already identified what that's going to, I mean, I know we're probably going to speak about it again on more than one occasion, but if we give hazardous pay to the employees at GMH, have you guys already identified how much that's actually going to cost against the budget submission? Do you have like a number yet?
Sorry, we haven't really done a financial analysis on it, because we're still going to establish a criteria as to what classification of employees are really more at risk to be exposed to those hazards. Like in the emergency room, patients that come in with whatever contagious diseases that we don't know until we do a lab test. So do we then give them that 10%? We have environmental health services, housekeeping people who are exposed also. So, of course, they would then get that hazardous pay. We have facilities and maintenance employees, but we also have office administrative staff who are not exposed to any of those hazards or any potential infections. So that's the financial analysis that we're going to need to put together.
And it's not like you've been here for like 2 years. You've been around the hospital for a long time. It's 2025. What do you think has taken so long for this type of effort to get here, and especially now? What's taken so long?
Well, we applied Many years ago, when I was working as a nursing administrator, we applied for hazardous pay, like for the operating room patients and for other classifications. Unfortunately, that application with the Department of Labor denied our request for the hazardous pay. So then it just never went forward. We just kind of dropped it.
Okay, and I know and I'll probably have more detailed questions in the second round, but when we think about the fee schedule for GMH, can you provide for the legislature today where you may be sitting at an update of the fee schedule for your organization?
Sure, I'll let Yuka speak on that one because
Thank you.
we recently had a hearing in April.
Okay.
Sorry.
I'm going to try and, okay, there we go. We do have quarterly hearings, public hearings on any new fees that we have, and the new fees consist of things like when we order a new supply or we're offering a new service and we need a new fee. That is done quarterly. Every year we do update our fee schedule 5%, which is allowed in our statute. But other than that, we don't really have any other updates to the fee schedule. One thing we want to do, because we've noticed a significant rise in the cost of our supplies, is periodically we'll take a look at what we're charging versus what now the current cost of, say, a certain supply is, because it's probably 10 times higher than what our rate is, because when we first established the rate for this supply, it may have been 10, even 20 years ago, and we're just increasing it by 5%, whereas the cost right now, when we look at the purchase order, it's an incredibly expensive amount. So we really have to take a look at that, because we want to make sure that our fees are in line with what our costs are. And we really did not have that problem before until maybe 2 or 3 years ago. We started noticing that, and I still see it today when I see requisitions on an item, and it comes back to me to recertify, because what we had thought it was going to cost is not the case. It's now double what we thought it was going to cost. And so immediately, and I'm thinking, well, how much are we charging for it? And when I look up the fee, it's not enough to cover the actual cost. So that's one thing that we do want to work on, is looking at what we charge versus what we're actually paying. Another thing that you need to take into perspective when we're talking about the cost of our supplies is that if the patient is covered under Medicare or Medicaid and they are an inpatient of the hospital, regardless of the amount of that cost of that supply, we're still only going to get the per diem rate for the day. So although we will always try to make our fee schedule in line with what we actually pay for in the supplies, we may not always realize that we're going to be reimbursed for that amount, even for a self-pay patient, because our collection rate for self-pay is very low. If an item costs $5,000, for example, more than likely a self-pay patient will not be able to afford a $5,000 stent or pacemaker and then pay the daily fee to stay in the hospital for nursing care and food and what have you. So, but as far as supplies are concerned, we will evaluate that cost difference.
All right, thank you so much, Yuka. Mr. Chair, that's all I have for this round. Thank you so much.
Thank you, Senator Gumatautau. Senator Burnett, you're recognized, sir.
Mr. Chair, and buenas noches, Mariquita, to the people of Guam. Thank you for joining us on this Sunday evening, and thank you to the panel for taking time out of your weekend to sit here with us and talk about your budget. Lillian, in your opening, you described the Guam Memorial Hospital as the beating heart, but I think anybody who's been to the hospital recently would probably say that instead of a beating heart, what we have is a bleeding heart up there due to the conditions. I'm very glad that the chair of the committee talked about the draft rifle document, because of all the things that were in there that were very, very concerning. One thing that I did see was this proposed budget for the Guam Memorial Hospital of $214 million. Right, that was the exciting part, the zeroing out of every single agency that perpetuates and promotes our Chamorro culture and language. For me, was very concerning, and I can absolutely understand why people would think that this draft document was quote-unquote anti-Chamorro. But that was the bad part of it. The parts that I liked were that the breakdown for education as well. The Guam Department of Education, according to this draft document, was funded at $306 million, which I thought was interesting because during the discussions for the Guam Department of Education budget, my colleagues were very hard-pressed to give anywhere near that amount. And so I guess my first
Point
question
of order,
is,
are we talking about rifle? I thought we were talking about this budget.
Mr. Chair,
Senator Barnett.
I
Mr.
have
Chair,
the floor and I'm
point
discussing
of order, are we talking about the budget?
Guam Memorial
Or
Hospital.
are we talking about rifle?
We'll keep the conversation to the.
I am
Guam
discussing the budget with the Guam Memorial Hospital. So my question, Mr. Chair, was
Thank you, Senator
in your
Barnett.
discussions with the Committee on Health and the proposed amendments that are going to be proffered on the floor, will those amendments bring your budget upwards anywhere near the $214 million mark?
I believe they will. We do have the shortfall that we had initially requested when we first came on board was about 21.9 million shortfall. So yes.
Okay, that's good to hear. I did want to also ask Lillian, I wasn't sure if you had an update on the hiring of the new administrator.
What new administrator? Oh, for my position. Okay, sure.
That new administrator.
That new administrator. The search committee has been meeting. And so far, I'll let Jesse update you because he's the one who's part of the search committee. I'm not. But thank you for that question.
All right. Thank you, Senator. So far, the search committee anticipates meeting this week. We received a total of 5 applications. They're going through the human resource process of evaluating if they meet the minimum standards as outlined in our enabling statute. Afterwards, we plan to engage with setting up the questions that will be posed to the applicants and then offering opportunities for community engagement so our stakeholders can meet with the folks that are vying for the job and pose their questions and see if they're really fit to handle the challenges the job possesses.
There was the matter of the consultant that was hired out of the Guam Economic Development Authority, and I know that there was some discussion on this across the hall relative to the deliverables from that contract, which were, again, supposed to inform the selection of the new administrator. First of all, do you have the document? Has it been provided? Or any other kind of status update on that?
No new status update. If you were following in the July meeting for the Board of Trustees, they had engaged a conversation about the draft report and sent their findings to GIDA. So GIDA, as the awarding entity, are ultimately responsible for accepting the report and then disclosing that to the public. But the Board of Trustees did disclose at their meeting that they desire for that report to be made public so everyone can see. Again, there's no jaw-dropping information from this report, but I think we can pose another request to GIDA to see what the timelines might be for releasing that report.
Okay, thank you very much. Lillian, in leading up to this hearing, kind of shook the tree just to get some concerns from constituents and people who have come into the Guam Memorial Hospital to receive medical care. And one of the things that I'm hearing is just it's the same things we always hear, lack of supplies. I've even heard from one of my aunties that there weren't any sheets and that patients were being advised to bring in their own sheets. So could you just generally give us an update on those types of issues and how this budget, in your opinion, will help address those very critical areas where patients are sharing with the members, right?
Yes, absolutely. Thank you for that question. Yes, that's been our challenge on a daily basis, the supplies, the linens, pharmaceuticals, and that's because vendors are not getting the timely pay that we owe them for it. Although we've been very fortunate that some of the vendors, despite the fact that we're behind in payment, they continue to provide us the supplies and the, what we need because they know that eventually we do make the payment. But yes, it's a reality. We do struggle with supplies. We do struggle with the linens. And so we have an update on the linens.
So just to update, we actually placed a few orders for linen, and they've, of course, it takes some time to get them in. And I believe just last week, actually the week prior, we received a bunch of them. And then just last week, we also received the flat sheets and things like that. So they're slowly coming in. We're monitoring the inventory for linen. The challenge we have really is that with the linens in particular is that it's inevitable. It's going to get damaged. It's going to get stained. And, even if we send them in to get washed, at some point we're going to have to discard those, and then we're going to have to replenish. And so we weren't entirely out, but yes, we were struggling for a little bit. And, we did get donations. I believe Dr. Eusebio and Dr. Christian Eusebio actually donated some patient gowns. We had some through the Volunteers Association. And we also had donations from, I believe, it's the Lions Club, and some others. So, recognizing the need, we do have some people donating linen.
So Radeline, what is the issue exactly? I'm just kind of reminded of, with the Guam Department of Education, they would have contract lapses with the MiFi devices, and that would lead to a gap in the services. So what is specifically the issue with the linens? And then further, the other concern I got from patients was I had one cousin who had a family member up there, and they said that the trash wasn't emptied for 2-3 days. So is that like a contract thing, or are you able to?
For the linen, it was actually the supply of the linen, the inventory, and so we took a closer look at it. And we were able to procure additional linen to get those in. And then for the trash, we did have an issue with, I believe, it had to do with the contract, but we got that resolved, so our trash is being picked up regularly. I know, you're talking about the trash in the back. No, we got that taken care of also.
Okay, so that was taken care of. The concern I had received was the room trash, like the trash can in the room wasn't emptied, so I wasn't sure if that was something with the custodial contract or...
No, so our the trash pickup is with our housekeeping staff, and so it's just a matter of picking up the trash. But there also are instances where it's in the middle of the night, and so typically with our housekeeping staff, they will not necessarily go into the rooms because we want to allow the patients to rest. And so if it's something like that, then normally it would be a discussion with the unit supervisor, and they'll just advise housekeeping. So as soon as maybe if the patient wakes up, then they'll be able to pick up the trash.
Thank you for that, but I'm just going to say I already know if they're watching the hearing, they're going to tell me like, oh no, it was 2 days. It wasn't, they didn't come in the night. So I just wanted to share those concerns from the constituents, and I'm not sure where they fit in the big budget picture, but no concern too small. All right. Next question I wanted to ask was about the above-step recruitment. Lillian, this is something I've always asked about over the years, but I wanted to ask how many above-step recruitments have you done in the last fiscal year, and how do you kind of, I don't want to use the word defend, but how do you kind of justify these non-medical above-step recruitments versus any, critical vacancies with medical personnel?
Thank you for that question. Yes, there is criteria, and so we use the criteria of difficult to recruit, or that position has been vacant for a while. We haven't been able to recruit anybody, and using their credentials, looking at their credentials, their advanced degree, and their years of experience. So yes, we do, and it's a tool. It's a legal tool that we certainly can use to recruit talented individuals into the hospital because I'm retiring, so I want to make sure we build our talented crew, talented, people to run that hospital. And so, yes, the above step is a very useful tool, very valuable tool. Thank you.
Thank you, Ms. Lillian. And so, the Personnel Services Administrator, Mr. Kenga, is that your title? Yes, so it was my understanding that the former Personnel Services Administrator, HR Administrator, I'm not sure the exact title, but left the Guam Memorial Hospital and was subsequently hired at the Department of Administration. And then I believe Mr. Kenga assumed that position, and maybe you can fill in some of the timeline. But was there a subsequent above-step recruitment announcement for your position?
Yes, there was. There has to be. In order to comply with the statutes that allow that tool, there's a public notice that gives an opportunity for individuals to provide comment. no comments were received, and I was just passing a message to our CEO. The question about above-step recruitments for the year, we have 40 that were done in this past year. Only 4 positions were for non-clinical. They were in the positions of IT and accounting, as well as HR.
And that would be you that filled the HR, okay, right. And I don't want to probe too much, but just, for the public scrutiny, but what special skills do you possess that warranted the above-step recruitment, or was it a matter of the positions? Because Lillian, you said if it's a long time to fill the position, but it's my understanding that it was filled pretty quickly after Mr. Uggan went to DOA.
Sure, sir. So Human Resources actually has developed a tool that would evaluate independently the individual's qualifications. And if you're asking for my specific qualifications, I possess a master's degree, 2 professional certifications, and 11 years of government service. So that was all factored in to evaluate the pay grade.
Thank you. Could you kind of expand on what are some of the clinical positions that you recruit using the above-step recruitment tool?
Absolutely. Most of them are for our hospital nurses. Those individuals, we have to compete with private entities like the Guam Regional Medical City, and so they offer premium pay. And in order for us to be somewhat palatable for a nurse to consider employment with GMH, we have to get to a salary compensation that seems at least on par. But I'll tell you, I think it's quite challenging because they seem to have better opportunities to raise the rates and the offers that they present, especially graduate nurses, which we simply can't catch up with. But we do our best to try to get to a salary that they will accept.
In addition, if I may, in addition to nursing, also allied health, like radiology technologists, physical therapists, occupational therapists, speech and language therapists, respiratory therapists that were short. So those are the other clinical positions that we recruit above step.
Thank you very much for that
welcome.
answer. So just to kind of expand on that, what are, I don't know if there's one or more than one, glaring vacancies that are absolutely critical to be filled, and with this budget as presented and as amended, I guess, give you the resources to fill these positions?
We do have one position that we've been trying to recruit, and that's the long-term care administrator for skilled nursing facility. It's a CMS requirement but we've been so fortunate in the CMS, they understand we've been trying to recruit. We've had applicants, but the salary they request is just way beyond our scale. So, that's one critical position. Thank you.
If I may say something, Senator.
Please.
One of the things that we're trying to do is recruit so that we can decrease the amount of overtime. By decreasing the amount of overtime while hiring somebody to fill that position, we'll be able to save some money. And so certainly recruitment is very, very important. At least I know from the physician standpoint, we're trying to work very hard at trying to do that, so that we can fill those positions. And obviously, physicians get paid quite a bit, and therefore, when they are working overtime, that increases the amount of expenses the hospital has. And so, getting somebody to fill those slots is very, very important for us at this time.
Lillian, sorry, just to go back to so really the only critical vacancy is for the long-term, to run the SNU up there in Barricade Heights? Okay. You don't need any, like, anesthesiologist, any of those
We
other
do.
Oh, you do? Okay.
We do. We need
Okay.
anesthesiologists, but they're not easy to come by.
Yeah.
So
that
yes.
would be one of the vacancies?
Absolutely.
Okay, thank you.
Yes.
Hey, what's the update on the travel nurses? So I know that because of the nursing shortage, and then, because of COVID, we've employed a lot of the travel nurses, but they come at, I think they're getting paid like $5 million an hour. That's a little bit of an exaggeration, right? So how are we?
I wish I was making $5 million.
Yeah.
But no.
Have we weaned off of that, or where are we with that?
Yes, we have. Thank you for that question. We are down to now 12 travel nurses. Most of them we deploy them into the telemetry unit, which is our cardiac monitoring telemetry unit. So we don't have any more in the ER we used to have. ICU, I think we are down to like 2. But the critical need now is the neonatal intensive care unit and the pediatric intensive care unit, which we have about 1 or 2. We're trying to recruit more. We're also very fortunate that the University of Guam BSN graduates, we now have, I think, 4 or 5 that have passed the exam. 6 have passed the NCLEX exam, and so we are getting them. We have 5, sorry. We have 5 now coming into the hospital. And a couple of them are now, they're interested and they are placed into the neonatal intensive care unit. So we continue to court those UOG BSN grads. Thank you.
Thank you.
Senator, one of the, I may put a plug in for Christine, our Director of Nursing, and she's created an environment where the nurses work, where they feel like family, so that there's a family atmosphere, and that actually attracts the nurses. Nurses from GRMC who come because they feel like part of the family at GMH as compared to GRMC.
Lillian, you know, it was, I think, a couple months ago, there was information that had come out about, and I think it was, again, across the hall in the hearing, doctors filling multiple positions and possibly receiving multiple salaries. How is that still an issue, Doc?
Actually, I'm working on that right now. Since assuming this role, I've had to meet with several of the physicians in order to identify exactly what they do, and also try to, if they don't fill in the slot that is my concept of what should be done, I'm removing the slot. So these are moves that we're making in order to try and decrease the costs.
And you said prior to filling this position, so could you just inform and I'm not sure if you said it, Lillian, I missed it. What position are you filling right now?
I'm a medical director.
Okay, so are you receiving an additional salary on top of?
Yes, I do, because I also take a surgical call. A surgical call which is separate from what I do as a medical director. When a patient comes in the emergency room and that requires a surgeon, then I respond appropriately. I take my turn as a member of the Department of Surgery covering the emergency room. There's only a limited number of surgeons, and so we all chip in and try and take call. And fortunately, I can do that as you know, as a surgeon and a medical director at the same time.
Thank you for your service. So the medical director position, what's that? How much extra is that, or what's that position pay?
I'm not sure how much do I get paid?
I think it's about,
I know exactly how much I get paid.
it's about 100,000 per annum.
Okay, so
Yeah.
Doc, I guess, so you're basically saying that you're kind of reviewing where there may be duplications of effort or doctors who are performing medical duties and then getting a little, you know, salary type addition to that. So what type of numbers are we talking about? And do you anticipate meaningful cost savings?
I mean, my goal is to make some meaningful cost savings, trying to decrease these directorships. There are some Medicare requirements that say that you have to have a medical director for hemodialysis, you have to have a medical director for intensive care unit, those kinds of things which is separate. These directorships are basically employees of administration, which is separate from what they do as, let's say, chairman of a department, which is more medical staff related rather than administrative related. So these roles are totally different and separate and required by Medicare as well.
Thank you. Thank you very much, Doc. And that kind of exhausts my questions, but I do want to end with just a little bit of commentary. And that I feel for the Guam Memorial Hospital. You know, in the 3 years that I've been in here, it's been the legislature that you come to with your hat in your hand asking for additional funds to basically keep your head above water. And I just have to express on the record my disappointment in what I believe is a lack of meaningful support from the administration. It is what it is, you know, and what I see maybe is, you know, when you get a new baby in the family and you have maybe the older kids aren't getting as much attention as they are used to, right? And so that's what I kind of think is going on with this new hospital, is that the administration has, in my opinion, turned almost 99% of its focus towards the securing and the construction of the new hospital. And the cost of that, I think, has been the conditions that we see at GMH. And I feel for you in being in this very difficult position where you come before the senators, and, you know, we all know they took the ARP. We all know that there's just been a lot of sins against the people's health care is how I would put it. And so that's always kind of been the challenge, is to get the honest answers and the, you know, the impartiality. You know, we spent, it was like a couple hours in there trying to just get you to say that, yeah, they took the money, you know what I mean? So that for me is just, is very frustrating, and I'm hopeful that you get a meaningful budget out of this, because I did receive your circular from a bunch of employees up at the hospital, and this circular impacted an already struggling morale with the employees. And you read it off in your open, Lillian, but I'm just going to reiterate that the legislature, with this budget as introduced, is considering a proposed budget for the upcoming fiscal year that will reduce funding for the Guam Memorial Hospital by nearly 15%. And based on our current operating needs, this reduction can result in that shortfall that you referenced of $28 million, affecting essential resources, services, staffing levels, and our ability to provide patient care. The circular further reads, if the proposed budget is passed without changes, we may face reduced resources for patient care, delays in repairing our facility, and delays in replacing vital equipment for clinical and IT functions, and limits on critical programs and potentially outsourcing services. And so, you know, just being in constant communication with a lot of the nurses over there, they do express just their frustrations with kind of like the day-to-day operations, and then, you know, receiving this circular and seeing once again that there could be a potential shortfall that is going to impact services which are already suffering, right? And so that's kind of my thought, is if you're, you know, 6 feet underwater and this budget, I'm just hoping that we can get you not just above water, but to a place where the people of Guam deserve. Thank you, Mr. Chair, for the time. Sidos Masi.
Thank you, Senator Barnett. Senator Terlahi, you're recognized, ma'am.
If I may say something, I think that the concept of the new hospital has been a detriment for us in GMH, because the concentration has been, oh, this is what we're going to do in the future, and blah blah blah, and don't worry, it's going to happen later. But the problem is that when the person that comes into the emergency room comes in pain and suffering and needs to be taken care of today. It's not going to happen tomorrow. We need the money today in order to take care of that patient. And I think the environment or the climate is such that people tend to forget that that's what we need to do. We need to still concentrate on today, and we need to put GMH today as priority, and all that other stuff about the new hospital is secondary. Yes, it's nice. Yes, we need it. But the important thing is we need to be able to take care of the patient today. If we can't take care of the patient today, we're in trouble. We really are. And that's the only people that are going to suffer are the people of Guam, and we don't want that to happen.
Doc, thank you so much for your candor in that, and I also agree wholeheartedly. And I mean, imagine what kind of GMH we would have if all that ARP money that they're putting in that sinkhole over there, Manila, went to you, like you said, today. Thank you, Mr. Chair.
Thank you, Senator Barnett. Senator Terlahi, you're recognized, ma'am.
Sidos Masi, Mr. Chair, and thank you to GMH for your work on this budget and for being here today on this Sunday. Just to follow up on that, Dr. Eusebio, I'm also very grateful that you said that there was several oversight hearings, and during one of them, there was a high-ranking part of the management team at GMH that admitted when we asked, why haven't these CIP projects been done? And he said, because we were told to work on the new hospital. And I'm sure you're aware that Lillian has had to be involved in the new hospital project and others on the GMH team. So You might be absolutely correct about that. But you are correct about we need attention to the current GMH, and that's what I think we've been trying to do over these years. It seems to be a struggle, but I'm glad we're all on the same page right now. So, and part of, just to follow up on that circular, so the circular says if you don't, that according to the current bill, you will be 15%, your funding will be reduced 15% by this bill. And that you're actively working with the legislature, closely with the Oversight Chair on Health, Senator Sabrina Salas-Mantanani, who introduced amendments on behalf of GMHA to secure additional funding with Senator Sean Gubintato and Senator Vince Borja. These amendments, if passed, will help close the funding gap. Then it tells the employees, your voice can make a difference. We help encourage the passage of these amendments and advocate for our legislative body to go further by identifying additional funds to prevent the planned budget cuts. So you believe that the floor amendments that you worked on with the health chair are going to close your gap? All right. When the last time we were in a GMH situation, it was like a $15 million shortfall. So the legislature, I think it was Speaker Blas at that time, Senator Blas, did an appropriation for $20 million, I think, and the governor was supposed to use, we did $30 million, and the governor was supposed to put $20 million ARP. So as you have testified in subsequent hearings, the $20 million ARP, you really only received $10 million. That was used for vendors, accounts payable, and you didn't get the money for the CIP projects. As you've described, you've had to use other money for CIP projects. But in the fiscal year budget request, the governor's request is $7 million less than what this bill provides. And it's $53.8 million. And she had at that time also enacted a fiscal review team specifically for GMH. All her top-level cabinet fiscal team was supposed to be helping GMH. So I'm just want to know, what is your understanding of how did you end up with $53.8 million if that is, as you put in your circular, not sufficient for GMH when she's enacted a fiscal review team and everything supposedly to help GMH? How did that executive budget request end up so low or deficient, in your words, for GMH?
Thank you, Senator Talai. If I may just clarify, what we put in that informational circular, the 15%, it doesn't close the shortfall, but at least it kind of narrows it down a little bit. We're still going to be short. In terms of the Fiscal Review Committee, we just recently met with the DOA director, myself, and Yuka. So really, yes, perhaps it's supposed to have the other top officials, the governor's, finance people from BBMR, but we haven't been consistently meeting. It's just been, even the last 2 months, we did not meet with the Fiscal Review Committee. Just last week was when we met with Mr. Edburn, DOA, and so we did not really discuss all the details of the budget, but that we did tell him that, we are going to be short for the fiscal year 2026 budget.
All right,
in terms of the governor's decision, I cannot answer for the governor's decision and the executive, budget team that she works with, for their fiscal, how they came about with this for GMH budget. But, we speak on our behalf, and I did speak with the governor that we're going to probably need to get more funding. And so, therefore, we appeal to the legislature because you do have that authority to appropriate more funding for the hospital and for the other government
since
agencies.
this request was received in January, I don't believe we've received any
other changes.
From the executive that this number should be changed. So again, the bill, I'm grateful that it's more. It's $7 million more than that request was No? Why not? That's what the budget chair or OFB said. What do you have?
So when you look at what the bill proposes compared to the EBR,
4 million?
you start with DOC Clinic. DOC Clinic was earmarked at 4.2 million, but the bill proposes 3.6 million, 3.65. For pharmaceutical fund, what was supposed to be around 25 million, the bill now proposes about 22.
Wait, when you say what's supposed to be, what do you mean?
So
The executive budget request?
The executive budget request,
Okay,
correct.
go
So we're
ahead.
comparing the EBR to
Okay.
what the substitute bill proposes.
Mm-hmm.
So for the pharmaceutical fund allocation with the reduction of the BPT, what was proposed in the EBR as 25 million is now about 22 million. And then the general fund saw the biggest decrease because it was estimated at above 28 million, but the substitute bill was at 19 million. Where they covered much of the shortfall, or at least partial of the shortfall, was there was an additional 5.2 million that the substitute bill proposes using FY23 excess fund collections. But there's still
So what is
an
it-
argument that could be made.
What, in your opinion, is the difference between the executive budget request and the bill?
About 7 million.
7
So
million?
when we,
Isn't that what I said?
yes,
Okay.
but the opposite. I think what was articulated was that the substitute bill was giving more than the EBR contemplated, but it's opposite.
All right, so.
No, correction,
Oh.
we did not. We said that we were 4 million less than you.
Okay.
So you
Oh,
have
then I-
7, yeah, we.
I heard, I
yes.
thought he said 57.8 and that the EBR was 53.8.
I'm sorry, it was 6, yeah. Wasn't it 6? I'll let him do it.
Yes, please, yeah.
So we're within $1 million.
Do you believe that this bill's 4 million less than the EBR?
I think when we added the total amount,
Senator, the difference is 6.7 million difference.
Up or down? The bill is less or more?
Down.
The governor's request is more.
Yeah.
Okay, all right, okay,
That's
then,
correct.
sorry, I heard that backwards. So that's what I was tracking until I thought I heard it differently. Okay, so, all right. And also, it's less than last year, right? It's 10 million less than last year, even with that additional FY23 excess revenues, it's still 10 million less than last year. So for some of the agencies, they've been treating what the supplemental gave to the agencies as like an intact new budget going forward. But for some agencies, and apparently GMH, they're saying that's not your intact budget. You really don't need that kind of operating amount going forward. That was just a one fluky type of thing. But at the time, we were facing huge accounts payable. We were hearing from nurses crying, or not crying, but very stressed about supplies and patients, as you heard. We all received those calls about patients and supplies. So when we asked you in May about the accounts payable, you told us that the grand total at that time, accounts payable, was 20 million, and that those over 90 days was 9.4 million. I asked you for an update, and thank you for the update. And so today, the total of accounts payable is 25.6 million, and those over 90 days is 16.469 million. That is a big increase from May, and I've even had vendors call asking, are we going to get paid? This is the issue, that they're just not getting paid. What is the plan to pay these vendors?
We do have some payment plans with some of the vendors, but it's really just been a struggle with the cash. As always, it's always a struggle. We do owe a significant amount. The highest amount on our accounts payable is to the New West Group, which is our travel nurse company. We also owe Guam Power Authority 1.6 million because we have not paid them since, I believe, January this year. And then the others are suppliers. The one thing that's been starting to creep into our accounts payable are the invoices for the CIPs, so projects and equipment that we purchased that we had already committed through the $20 million ARP funding. So now that these invoices are starting to come in because we're receiving the items that we had ordered, we have a new transport, we have a flatbed, we have the ER triage door has been repaired because it had been broken for a really, really long time. And now we're responsible to pay for these items. the priority for me has always been the supplies because the vendors will stop the deliveries of the supplies. So that is all. If I have money set aside to pay power, for example, and then all of a sudden we have a desperate cry from the materials management department saying this company has put us on hold and they are the only ones that have this supply, I have to divert that fund and the money that we were holding for power and give it to the company that's going to give us the supply, and then they deliver it and everything's fine. So this has been the cycle of the cash. But we really try to work with the vendors to pay them. Some of them are really good with just even a small payment just to keep the account moving. Even if we owe them, say, $300,000 and I tell them all I can pay you is $50,000, they're okay with that. So that's how we've been working with them. But it is a challenge. It's a struggle because we don't have enough cash.
That's not what I've been hearing from some vendors. They're not happy at all. They want to be paid. So what was the plan if you had received the executive budget request amount? How are we going to take care of the over 90 days, $16 million due?
That's a good question.
Fiscal Review Committee had any recommendations? All right.
And that was one of the things that I had found was the excess in the pharmaceutical fund was one area we thought we could tap into to at least get extra cash in to pay down our payables, because we went all the way back looking to, I think, 2020, 2019, and just looking at those audited figures on the pharmaceutical fund versus what we actually got in cash. And there's a gap. There's several $million.
What is your estimate in FY25?
So I can share
Of the gap.
FY25 alone is nearing $725,000.
That's the gap,
Yes.
you're saying?
Correct. Because if you account for what is the collections, actual collections reported in the consolidated revenue expenditure report to the adopted levels, 6.19% of that equals to $720,000. We can get you the actual figures. In addition, for FY24 and prior, those amounts add up to 10.
Pretty much been accounted for either today or in past budgets, but what we did, I was able to put in an amendment in Chapter 1 of the bill to account for FY26. So if there are any additional revenues that come in, that they should be going to you in the percentage as required by law, 6.19%, regardless of the amount that's put into the bill. So that everybody supported that amendment, so that's good. I know you're talking about nurse recruitment. There was a nurse recruitment thing in the last budget that got line item vetoed, but if we, I am very concerned about these vendors. I think, I don't, want to imagine about the gown situation and all these things, that it's because we can't pay our vendors, and yet we have no real plan to pay them. That's my big concern. It's like even with the budget request from the executive branch, even with this bill, even with the additional pharmaceutical funds, we're never going to find 16 million. I mean, maybe I don't know how, Mr. Chair, we'll have to work on that. But that's going to be another big, huge emergency, like we had with the 30 million. It had gone all the way up to 30 million at that time. And we're at 16 right now. I see the CIP projects, you're trying to complete them, you're shuffling funds in order to try to complete the most urgent ones. Thank you for the work that you're doing on these and that you had to accommodate when the ARP money was removed. But again, we're still 10 million less than what you received in FY25. But do you believe that additional supplemental 10 million is necessary for GMH going forward? What do you calculate to be the 15% that you're lacking, or that you said in your newsletter to the employees? Is that 8.6 million or 5.6 million, something like that? 15% of your budget?
The operational gap is $28.2 million today. That's what we're going, without any amendments, and so we haven't yet seen if the body introduce or have passed anything outside of your amendment in Chapter 1. But if nothing changes and the bill passes as is, the gap will be 28.2 million.
Is that from your request? Or
From our total operating budget. So if we look at the total request for GMH, 213 million, 63% comes from net patient revenues. The rest
right.
comes from the other funding sources appropriated by the legislature.
Okay, and so Lillian, you're saying nothing from the Fiscal Review Committee is guiding you in what to do about these accounts payable? All right, then was there anything in the consultant's report, and I know that he made a presentation to GMH, that, is there anything in that consultant's report that makes recommendations as to how to improve the fiscal health of GMH? Because we haven't seen that, and we've asked GMH and we've had GIDA, and both refused to be transparent and give that to us or show it to us, but I feel like we've paid this money for the consultant, and the whole entire people of Guam are entitled to the results or recommendations.
Senator, but
yes.
again,
All right.
like it has already been mentioned, we don't own that report.
Yes, I know, but it's
GIDA
been
that
presented
owns
to
it.
the Guam Memorial Hospital. You're using it for your operations.
We're
so,
not using it for the operations, but because we haven't
okay, so what
accepted
in
it
there
yet.
is recommended for the fiscal health of GMH?
Well, one of them that's recommended is the insurance reimbursement to negotiate, because that's one of our challenges, is not all insurance companies are reimbursing the hospital, not even 70%. We do have one insurance company that owes the hospital, and we're challenged with that company. And so we're working with that company to try and get them to reimburse the hospital for what they owe the hospital for the services that we provide their members. That's been one of our biggest challenges. We settled with that insurance company, and in that settlement of twice settlement, we lost about $8 million. So, you know, that's been our challenges with the insurance. So that was one of the recommendations in the draft report by the GIDA consultant, was to try and renegotiate the agreement with the insurance companies. I can't remember the other recommendations in that draft report, but again, as much as we want to make it public and everybody to read it, it's really the GIDA owns that report. They just want the hospital, because they did it, the consultant did it on behalf of the hospital, looking at its operations and its finance. And so the recommendations in there is still in draft. And we've also asked the consultant to give us more specific deliverables and specific strategies. And so we're waiting for that.
All right.
Point of information, Mr. Chair, if I may, just to chime in as the Oversight Chair of GIDA.
Go ahead, Senator Taidewa, you recognize.
Thank you. Just regarding this agreement, you know, for the recommendations, from what I gather, that one of them, you're asking what was the other thing? I think it was software upgrades that was requested from that. It was just very few little things, the software upgrades, and then they're going to, in 6 months, provide you long-term corrections that will be made. So that's the second part of it. So I just wanted to give that information.
Thank you for the information.
Point of
Senator
information, Mr. Chair, as the Oversight
yes,
Chair of the Committee on Health,
Yes.
I did receive communication from Mr. Lika. I have been seeking an update, right, on the professional services agreement. So I do have an update from him on the status of that contract, and I can share that with you, Senator Terlahi, now.
Senator Terlahi and Senator
Yes.
Montanani.
I appreciate the follow-ups from the different senators. My issue is we have these issues. We've had issues already with the insurance companies, and I can't believe we needed to wait for that audit or that consultant to tell us that we have a problem with collecting from some of these insurance companies, or that just seems obvious to me. And that's what I was worried about, and that's what I want to know. Are we getting some real recommendations to improve the fiscal health of GMH or not, right? And if we are, then why aren't we going to implement those right now? Or why aren't you going to talk to us and tell us, let's do this right now? Why are we going to wait? And, you know, we've put on hold a public-private partnership to make changes in an organizational structure for GMH or a management structure. hoping to see if what this consultant says, because that was recommended by other
Thank you, Senator.
task forces and
Yeah.
and consultants.
Thank
So
you, Senator.
I just want to see if this consultant's consistent or not, and why aren't we going to move faster in making these implementing these changes? All right,
Thank you,
I'll wait
Senator
for
July.
round two. Thank you. Thank you
You're
very
welcome.
much.
Senator July, I want to ask you to join me because I don't agree with that past due can't be made up. You know, this is transfer authority season. And the truth is that that's the reconciled cost. And it's not, it wouldn't be like the governor transferring in to GMH because it's just because they're, you know, as a special unit entity, not to just do a outright, they need an appropriation. I don't think we should have to have an appropriation for past due that is duly and rightly due to them. So I would ask the governor now to, this is when, they said this on the record when they came here, we use our transfer authority on the end of the year when the reconciliation of accounts is required. I think they can get them $10 million in the next couple weeks, really. So please join me in that. Senator Montanani, you're recognized.
Thank you, Mr. Chair. I somewhat agree with Senator Terlahi in terms of paying vendors and what you've mentioned as definitely a priority for GMH. But in terms of bringing in revenue, one of the biggest, I guess, issues and even obstacles really is your IT network. So I think for the public that may not be aware, because I don't think I saw it in the media, the problems that you've been having with your IT network. And I think it just occurred twice this year, that at least that I know, and that I'm aware of. And not only can you talk about it, but just how much in delayed payments it has cost the hospital.
Thank you, Senator Montanani. Yes, the two incidents that we had, and most recently, July 28th, we had a power fluctuation. And with that power fluctuation, one of our 30-year-old equipment called AIX, which is the accelerated or advanced interactive executive, that's a device that interfaces the registration and the billing. It powered up, but it just did not do the connection. And so therefore, that's why we have problems with the patient registration and the billing. And of course, it impacted our CareView, which is our electronic health record. And so there was a little bit of a miscommunication with the company called IBM that we contract, because it is an IBM equipment. We contract with them. Unfortunately, the IBM representative that's on the island was on vacation, so we couldn't get his support, his technical support, and you know, to help us through that. The Honolulu IBM office.
Lillian, can we just dumb this down a little bit? Maybe just say, like, for 5 days, we weren't able to use our internet.
It took 3 days.
3 days.
It took 3 days.
We weren't
then
able
once
to
we
use
got
our
that
internet.
powered up, the internet went down because the sonic wall did not, again, it went down. But we were able to get IT&E to help us out with that one. So we recovered the internet. But yes.
So how many days? 3, 4, 3 plus?
By the time that we were able to get the IBM to get our AIX up and reconnected, it was about the 3rd day. And then when we got it, the internet went down.
So how many days total?
4 or 5 days.
4 or 5 days. So
yes.
4 or 5 days, let's just say 5. How much in revenue did you lose, or it was delayed? How much were you not able to collect?
We were not able to bill. Go ahead, Yuka.
Right now, we don't have the impact on it because it just happened, but the impact on productivity is definitely there. When we lost the systems, the billers, coders, no, they don't have anything to do. And yes, of course, the charges were collected manually, and it took about a week maybe to put all those in. So all the charges are in. It's really on the productivity side. Now we're having to pay a lot of overtime to get caught up on these things because we can't go back to 8 to 5. We're going to need to put in extra hours, and everybody put in extra hours to get all those charges in, and now we're going to need to put extra hours to get those billings in. And the main thing is we want to make sure those bills are in on time. We only have 90 days to bill the insurance companies, and so that's the main thing on our mind, is getting the claim in that time period. We did reach out as a precautionary measure to all the insurance companies to let them know, can they give us an extra 30 days? Because we weren't sure how long we were going to be out, but fortunately, it was just for 4 days, so we retracted the extension. But when these things
just
happen,
a ballpark figure with everything, with personnel costs, because I know at one point when I asked about it the last time this occurred, it was about $500,000 in delayed billings to, I think, Medicare, and then another $500,000.
so far we don't have any delays.
No. When your IT system goes down and you have to manually right.
Oh, the charges. It is roughly maybe $700,000 a day, $700,000 a day in charges.
For
Multiply that by the 4 days, so 7 times 4, 2.8 million delayed, plus the costs that are involved in catching up with everything.
And again, that was just for the July incident. It occurred again when again? March? I think it was March. And how many days was that?
That was very short, maybe 2 days? 2 days.
A short time, 2 days.
So how far on a priority list is updating your IT? And how important is it to update your IT in collecting? Because you guys do have a corrective action plan, is that correct? That was submitted to HHS along with a fine that you paid?
Yes, that is correct. We do have a corrective action plan with a vendor that has already completed the risk analysis, and so now we're working on the risk management plan. We submitted that to HHS, and so we're just waiting now for their approval. And that risk management plan is tagged at $5 million per year for a period of 5 years.
You mentioned that the last network failure was due to a power glitch?
Also, correct.
Do you guys have like is that tied to an electrical panel, if your electrical panel was working? Or I'm just...
The power source, the power backup, the ops we have, but, again, it's not as a robust ops. We're getting an enterprise scale ops that it's going to be arriving in about 2 to 3 weeks that we just procured, and that will it's a very high level ops that is used in the industrial industry, and so it's a high level ops is what we're going to be installing.
Maybe Zaldi, you can answer. How old is the electrical panel?
The electrical panel, when I first started in 1986, it was already there. Over 30 years.
So also that's critical, right?
Yes.
It's a single point of failure, ma'am. So if everything goes down, main distribution panel, the hospital might as well just close up. We should evacuate.
Number one priority.
If I may add also, Senator, on the related to the IT and to your question on how critical is it or how important it is for us, it is certainly very important. In fact, it's the $5 million of our $29.3 million is specifically for IT network infrastructure. And so again, the critical need of our CIPs, 5 of the 29 million was for that purpose.
Was that also part of the 10 that was taken away? In ARPA?
Partially, yes.
Kind of figured that. I did want to follow up on any revenue generating opportunities for GMH. I know that we had discussed the possibility of the SNF. We toured that facility early on when I was elected, and it's a beautiful facility, but severely underutilized. I know, Lillian, you had mentioned there could be potential.
Yes, correct, Senator. Thank you. There is a company that is Texas-based. The company provides inpatient rehab therapy for individuals with stroke, individuals with other, mobility issues. So what that company wants to do is rent a portion of the skilled nursing facility, and what they're asking is possibly 18 to 30 spaces that they can then use and they want to rent. So that is a revenue opportunity, revenue generating opportunity, but we haven't gotten a formal proposal from them. We're waiting for that to then discuss it and bring it to the board level, whether or not that is something that we want to continue and pursue and be in an agreement with them, engage a contract with them. But we're also looking to see and make sure that this is not an unsolicited offer, although it's not a procurement for us, but it is going to be a revenue for the hospital. So we need to make sure that we clear the path in terms of it being an unsolicited offer or not. Yes.
TEFRA, is there any update on that?
No, ma'am, we haven't heard back from Congressman Moylan, but they are working on the, I'll let Yuka speak more on it.
Draft legislation? Or?
There is legislation in the Committee on Health, I think, and it's, I don't remember the bill number, but it was drafted to designate GMH as a territorial safety net hospital, which would reimburse us the same way as a critical access hospital, or 101% of our costs. So this is significant legislation that's really going to help us. It could double the amount of money we get from Medicaid, and of course from Medicare, because our Medicaid follows the Medicare rate. The last I checked, it is still in the Committee on Health, but I've been communicating with the congressman's staff, and he updated me, must have been about a month ago, that the congressman is going to push some bills out in some, there, HR 9128 is the title of the bill. So you can follow it online, and so we can see like where it is in the whole process. I'm not too familiar with how fast these things pass through Congress, but the Congressman's office has been very good at updating me on where it is. When I ask, they're very good to offer where it is. There hasn't been any movement on it, but it's still there in the committee.
So it's different from what the administration has been talking about in terms of we should move to PPS, the prospective payment system, and also different from TEFRA, which they've been working on since last March, and different from the critical hospital designation.
Yes,
Completely
because
new.
we don't fit the criteria for the critical access. So this is a nice compromise. So what it did, it takes the legislation for the critical access hospital and slips in this territorial safety net hospital in the same in that same vein.
Okay. Well, I can also follow up with Congressman Moylan's office, so thank you for that. I did want to go over some of the amendments while I do have time, because you might not be here when these amendments hit the floor, because a lot of them are under miscellaneous provisions. So I wanted to ask you about and give you the opportunity to talk about the amendment that relates to, there's a lot here. I believe I have one in here for the Department of Corrections, and moving money that otherwise would go to DOC directly to GMH, and why that just makes more sense. If anybody would like to.
The money that's appropriated to DOC is not enough to cover what we bill them every month. So, for example, this year they got $3.65 million. We're invoicing them already the July, and they're not going to be able to pay that whole bill. So we'll probably get, I think, about 30% of the July, and August and September will not be funded. So it's not going to be enough money anyway. They do pay us. We follow up on the payment, and DOA does pay us, but it's just there's not enough money to pay all the invoices.
Right. If I may add, they also, when they bring the inmates into the hospital and are admitted as inpatient, they haven't reimbursed us for that. That's about $5 million.
It's about $4 million, but these are for very old invoices that they never paid way back from 19 or whatever. I think it's actually we go back to maybe 2012 or so. Those haven't been paid. But in more recent years, DOA has been reimbursing at our Medicare rate. So we're getting roughly 20% of what we bill. And we recently sent them the bills for, I believe, FY2025 so far to date. And they did make a payment, but we haven't been able to identify what those, because it just came in just like Friday. So we don't have the details of what that payment is. So we should be getting that this week, and then we can apply it to what those invoices are. But there are some very old accounts that we want to write off because we don't think we'll ever get paid, but the board does advise us, our board, that to try and get that money through an appropriation or whatever.
When you say old, how old?
They could be as old as about 20 years old. Yeah, because the inmates have always been coming to the hospital to be treated for a variety of things, and really in the past, we were never paid for those.
Senator, if I may add that it just seems to be a matter of good policy. The individuals that staff the DOC clinic are GMH employees, and GMH is responsible for procuring the supplies and everything that's utilized at the clinic. So rather than creating an added layer of bureaucracy that needs to be a pass-through, it just makes more sense that you just automatically appropriate it to the hospital because we're allocating those resources to DOC.
One other amendment that we'd been working on was enhancing GMH's ability to procure critical medical equipment by extending the existing tax credit program and eliminating the 1% administrative fee. GMH plays a vital role in providing life-saving care, but continues to face challenges in acquiring essential medical supplies. Removing the administrative fee ensures that the full value of the tax credits is directed toward high-priority equipment needs, maximizing the program's impact. Additionally, adjusting, and I think this is one of the most important part, the effective date of October 1st, 2025, which allows for proper implementation. So essentially, we have to amend it either way because it expires at the start of the new fiscal year. So if you would like to talk a little bit more, because I'm sure that my colleagues may have some issue, because it poses a potential loss in revenue to another government agency.
We had an opportunity to, a vendor was willing to use the tax credit program, I think to the tune of $3 million, so that we can use that to procure medical equipment. Unfortunately, because it did not get into the appropriation bill last year, we could not then avail that $3 million. The other factor was that that company, because of that 1% application fee, was very hesitant to then move forward with using the tax credit program of $3 million for the hospital because of that 1% application fee.
And are you aware how much in tax credits are available, I think have been collected so far?
Are we aware of the tax credit being available?
Right, because I was reading an article that there was the $3 million that you were on, GMH was not able to access.
Right. The tax credit program is administered by GIDA.
Right.
And so when we first got wind of it, that's when we started, asking and looking around, and we even have a list of medical equipment that the board approved to avail that $3 million, but we couldn't go forward because the vendor that was willing to use that tax credit of $3 million did not want to pay the 1% application fee.
Okay.
Also, Senator, to reiterate, the public law that avails of the GMH tax credit gives just an authorization for this program to exist, but no appropriation of funds. So when a vendor appears and submits that they want to procure such supplies, we have to factor if the budget bill that was enacted contemplated a reduction of the tax revenue by that amount. And so since its enactment, the legislature hasn't appropriated that $1 million reduction to avail of this tax credit. Only in 2026 budget bill is its first contemplation of being funded.
Thank you. I think for now, I'm going to hold off the rest of my questions until the next round. So thank you very much.
Senator Parkinson, you're recognized.
Thank you, Mr. Chair. So, thank you for being out here on a Sunday. I appreciate your dedication to the budget process. I wanted to ask about some of the staffing and personnel shortfalls. This is regarding the nursing workforce. The ICU, CCU has 14 beds, yet due to a lack of skilled and competent critical care nurses, the unit bed capacity may be reduced. I would just like to ask, how is GMH addressing this nurse shortage? And what portion of FY2026 budget requests for nursing was intended to hire or train additional ICU nurses?
In terms of the bed capacity, physically, yes, it is structured to have 14 beds. Because of the staffing situation, we can only accommodate 12. And we've used the other rooms for storage and storage of equipment, storage of supplies. We are using travel nurses in the ICU. We have implemented a specialty pay for the ICU nurses, and that's part of our recruitment strategies. And we have been quite successful in recruiting nurses and retaining them, but we still would like to recruit more so we can open up more ICU beds to accommodate those patients who end up waiting and holding in the ER who need ICU beds.
What are the implications for patient care if those positions remained unfulfilled? Because, I mean, we're kind of planning around 14 beds, but now that you're telling me there's 12. So what kind of strain? Because, I mean, it sounds like it's 2 beds, but when you only have 14 beds, it's a significant number. So what kind of strain does that put on our existing resources?
Correct. Well, the strain is on the emergency room. And so these ICU level of care of patients end up waiting in the emergency room till an ICU bed is available in the ICU unit. We do also have patients who are not ICU level of care in the ICU, such as telemetry level or even progressive care level, meaning they're just in between telemetry and ICU, occupying those ICU beds. If we can move them up, that way it can free up those ICU beds for those ICU patients.
And correct me if I'm wrong, but I understand that ICU beds are a little bit more efficient than using the emergency room for the same purposes. Do I understand that correctly?
They're a lot more comfortable than the ER beds, because the ER beds are stretcher beds, and so they're not all that comfortable for the patients. But they do have one-on-one nurse ratio when they are ICU level of care.
Okay, I want to talk about the full-time equivalent increase. The administration requested funding for 60 FTEs, full-time equivalents in 2026, up from 50 authorized in 2025. This corresponds to an increase in the admin budget from $6.55 million to $7.29 million. Were these 10 new positions approved and funded?
They're not new positions, Senator. Again, if we wish to grow our patient bed count, we have to recruit additional nurses. And so the realities are what the budget proposals reflect is a budget shortfall. I think Your numbers and what you're sharing with the panel here reflects our desire to recruit additional nurses so that those patient beds.
I'm sorry, that's for the administrative portion, administrative division. They requested 60 full-time equivalents in 2026, up from 50. So I was asking about the administrative side.
So administration also includes our medical directors. So every direct report to the CEO could be found in the administration section.
So there's some crossover there.
Correct.
How much crossover would you say you have in the administrative versus the medical capacity?
I would say 50%. So positions like the chief medical officer is a position held within the administration budget and not in the medical services budget.
Okay, and I did have a question about the skilled nursing unit, though. The skilled nursing unit is Medicare certified for 40 beds, but shows a drop from 59 full-time equivalents in 2024 to 55 full-time equivalents in FY25. So did last year's budget cuts force a reduction in that SNU staffing, or what was the cause of that reduction in staffing?
It would be budget cuts, Senator. So if there aren't enough resources to support the positions funded, so they get reallocated to other categories like nursing administration if sufficient resources exist to fill said position.
Okay, and then for the skilled nursing unit capacity, what impact does this have on the staffing levels on patient admissions? Does that compromise the 40 beds that the skilled nursing unit's rated for, or what's that situation look like?
Yes, and ultimately, I think working with our nursing director, we try to find ways in which staff at the main facility could be reassigned to SNF to fill those critical needs.
What kind of capacity are you looking at right now if it's not 40 beds?
We capped it at 20.
So
Our capacity is at 20 for the skilled nursing.
our 40 bed capacity is down to 20.
Correct, and has been for years, because we're so short of nursing staff for that skilled nursing unit.
And that's with 55 positions funded, we're at half capacity.
Well, it's 55 positions because there's nurses' aides, there are physical therapists in that for SNU, there are dietary people, there are FM people, housekeeping people for that facility. So it's not just nursing, but also those other support and ancillary.
So how many full-time equivalents do you think we would need in the skilled nursing unit to reach our 40 capacity for beds?
I haven't factored that, but we can certainly do a calculation of it, how many, to determine how many that we really need. And we also need a long-term care administrator for that facility.
Yeah, I would certainly like to know that number, because if we're going to be sending resources to the hospital, it would be nice to know that that would actually be going towards our medical capacity.
Sure.
You know, I think there was a recent study of our wastewater systems, and it shows that there's an awful lot of COVID out there right now. You know, I know we're kind of back into the post-lockdown world, but these diseases and things are still out there. They're still a factor for us to consider, and we can't be caught slipping, letting our capacity slip in case we have another pandemic
Hopefully not.
Or not even a pandemic, but just an epidemic or smaller scales that could affect us regionally. You know, I remember what it was like with bird flu and the like growing up when I was in high school. So we're no stranger to diseases coming to this island.
Correct. We don't know what emerging contagious diseases.
So let's talk about infrastructure and capital needs. GMH is, actually first I got a question about the hospital life expectancy, because I know one of the amendments that's up for discussion later is to transfer some of the funding from the new hospital to this hospital to pay for some needs. And so, you know, I'm not on its face necessarily against this idea, but I do got to question the wisdom of when do we actually put money towards a new hospital if we're going to be using it like a piggy bank like this when we need the extra help, because from what I understand, the hospital, I remember, what was it, talk that the hospital had 5 more years of good life left, and I feel like that was like 10 years ago. So where are we on the life expectancy of this hospital, the useful expectancy? Especially if we're going to be looking at ideas like pulling funding from a new hospital to fund this one.
I believe, sir, we already exceeded the life expectancy of 50 years. But then again, if you consider the location of our facility, it's right there on the brink of, subjected to salt spray, which would speed up the deterioration.
Okay, so let's talk about some of these deferred critical projects. GMH's 2026 capital improvement project list identifies about 40 million in urgent projects. 29.3 million are unfunded. From what I see, this includes major structural and safety upgrades. For example, the Z-Wing building is unsafe and at risk of collapse in a strong earthquake, and the main hospital roof has exceeded its useful life. So, of the 29.3 million that is still unfunded, which significant capital needs are left unmet, and how are you prioritizing which projects to tackle first?
Of the 29.3 million,
Yeah, I see that there's, out of the 40 million in identified urgent projects, I see that 29.3 million are unfunded.
yes. So as part of this budget request, we were requesting for the $29.3 million for the legislature to consider to provide funding for the hospital. Again, a big portion of this is, there's $14.5 million here for the new electronic health record, another $5 million for our IT infrastructure projects, about $5.1 million, $5.2 million for the removal and replacement of our main electrical distribution panel, sub-panel emergency generators and access road. And again, these that I'm mentioning, these are just for 1 year, recognizing that, for example, the electronic health record, and we've said this in multiple public hearings, is that we are estimating that a new electronic health records can cost us upwards of $60 million for a 5-year period. But recognizing that the first year of an EHR would require a little bit more funding, and hence the reason why we're estimating about $14.5 million. And that's what we're requesting for. In the past, we've also been asked where we at, because we have made mention that our current electronic health record as it is not adequate for what we need it for the hospital, for lack of a better word. But in order for us to even begin the procurement process, we need to secure funding, and hence the reason why this is part of our budget request.
Forgive me if I'm wrong, but I seem to recall that for this medical health system, this is not the first time you guys have gotten a system like this. This is like the 3rd or 4th time a system like this has popped up, hasn't it? How many times have we purchased a health record system like this in like the last 10 years, 20 years? How many systems have we bought?
This is probably...
For a long time, we had the Optimum, which is owned by Cantata, and that's what we were using as our electronic health record system. However, they sunsetted that EHR, and from sunsetting that, we then used the innovation process to then switch over and transition to the current EHR system, which is CareView, owned by MedSphere. When we did that transition, we were convinced that it was going to fit our landscape. Unfortunately, we discovered that it doesn't, because it was originally configured and programmed for an outpatient behavioral health facility. Our team rebuilt it and made it fit into our landscape. However, it's missing pieces and missing parts for our clinical people to use. So it's really not the most effective, most efficient EHR. So we need to procure a new EHR system.
So I'm trying to understand, how was your tech team not able to figure this out before it happened the third time? Because I have a real concern, because I heard 3 different EHR systems there, right? So this would be the 4th one that we're going for?
No, this is not the 4th one.
This is the 3rd one?
This is about the 2nd one, because we had Optimum for many, many years. Then we switched over
To another
CareView,
one. And
which
so
we just
CareView
launched.
So CareView would be like
We
the
just
second one.
launched it in 2022
And then you want to switch from CareView that you've been on since 2022 to a 3rd system.
to a 3rd system.
How much did the first system cost?
That was a long time ago. Optima, I have no idea how much it cost.
How much did the second system cost?
The second system, we started out with $5 million.
5 million. And then this next system could cost up to 60 million.
Well, you know, through the technology today, it has gone up. Prices have gone up.
No, I understand that completely. Prices do go up. My concern is, what steps are you folks taking to make sure that we're actually buying the proper system? Because the cost from 5 million to 60 million is a significant jump, and we cannot afford to have another, oopsie, this system doesn't work.
That's why we're going
So that's
through.
why I'm asking, why were we not able to figure out the first system, what didn't work, and what's going to be different about this go around?
Well, and that's why we're going through this process with the risk management plan. The team has done an assessment on our hardware and our software and identifying what is it that we need to have in place to ensure that the next EHR is going to really fit our landscape. At the same time, will be very efficient and very effective when we launch it.
If I may add to that, and so yes, recognizing the IT risk management plan, as well as the risk analysis that was recently done, clearly there are things that we need to work on, but we also recognize that buying a new EHR is not going to mean anything if we don't fix our current IT infrastructure as it exists today. And so hence part of what we were asking for the FY2026 CIP was $5 million specifically for our IT network infrastructure to revamp that. Because, I mean, you can go to the hospital today and, you know, you'll recognize that there are areas where to this day you can't even find signal on your cell phone because, you know, we're lacking simple basic things like that. And so part of the $60 million and then this $5 million that we're talking about for the IT network infrastructure is really to fix those basic pieces as well as hardware that we need, because recognizing that even if we get a new EHR, we're going to need to upgrade our hardware as well, because I'm pretty sure a lot of the current hardware that we have will not be compatible to a new EHR system. So all of that is being taken into consideration by our team.
60 million for an EHR, and then how many million for a new IT system?
For this fiscal year, we were budgeting $5 million for the IT network infrastructure. That's basically to upgrade our current infrastructure.
So all in 65 million to get a new EHR system.
Well, the 60 million was for estimated for a 5-year period.
Over
So,
a 5-year period.
Yes. So
that's
just
so
for
about 12 million a year.
yes, roughly 12 million. But as I mentioned already, we budgeted a little bit more for the first year, knowing that we're going to need to get some additional hardware and so on as part of the EHR. And so also to answer your question about what exactly are we doing to make sure we're getting the right system, we're also, we actually put together a draft RFP for a new EHR system, which we did already request for feedback from our end users. But again, because we're in this process, we'd like to actually push it back out to our end users again to verify, since we still don't have a funding source anyway, but just to make sure that all the pieces that need to be in there are already contemplated as part of that RFP.
Okay, so this is a program over the course of 5 years. So if theoretically, if you guys were to make a mistake and pick a wrong system again, we would be on the hook for this system for 5 years. There's no early exit if this is not the program for us.
Well, that's the reason why it's very critical for us to make sure that we take a look at all of those pieces. And I think that everyone has kind of learned from this last go-round of the things that we need now. And so we're going to make sure that those pieces are included.
I would certainly hope so.
And just to clarify, under the procurement code, we just need the funding for year one of things, procurements, because all subsequent years are subject to funds available. So it's not going to put us on the hook for 5 years. If there is a problem, the struggle is if it's not working, we can't just shut it down and go back to manual mode indefinitely. We'd need to find an alternative to do it. So we're not necessarily stuck with it for 5 years, but it would be the 5-year cost estimate is the $60 million.
Oh boy, so I see that there are several critical facility systems that are also waiting for funding. For instance, the main electrical distribution panels are non-compliant and aged, and the hospital has an incomplete fire sprinkler protection system that is outdated and an outdated fire alarm system. Yet the budget shows no capital outlay approved for these in 2025 or 2026. How is GMH figuring on ensuring patient and staff safety in the interim if those things are not being addressed in FY25 and 26? Are there temporary fixes or workarounds in place for the electrical and fire protection system? Like, what is the risk of not finding these life safety upgrades, not just in terms of human life, but in terms of code compliance, insurance liability, and other unthinkable worst case scenarios? Like, let's talk to me about this.
The fire sprinkler system and the fire suppression system is a specialty service that is being procured from a special provided. So in-house testing also is being done as part of our preventive maintenance, because not all of those are being provided by specialty providers.
All right, I think that's my time. Thank you, Mr. Chair.
Thank you, Senator Parkinson.
If I may add, just to clarify, so for example, for the main electrical distribution panel, again, we do recognize that this is so important, and as Mr. Zaldi had already mentioned earlier, this is a single point of failure for us, and so because of that, we've actually submitted a grant application to FEMA on their hazard mitigation grant program to kind of see if we can get this. I believe we looked at another funding source, which we also, I believe it's the DCIP, the Defense Community Infrastructure Program, because again, we recognize that the legislature can help us, but also recognizing that, you guys are also limited in what funding you can provide, and so we're trying our best to seek other alternative funding sources, but any help we can get, of course, is definitely appreciated.
Thank you, ma'am. Senator Parrish, you have any questions?
Yes, I do. Thank you, Mr.
You're
Chair,
recognized,
and
ma'am.
good evening to GMH panel here today. We do appreciate you being here. Just to kind of recap the budget. So in your presentation at the budget hearing, you stated that your operating cost is $213 million, is that correct? And that 63% is funded by patient revenue, and that equals to about $134 million. And then today, the legislative appropriation is at $47.1 million. So I calculate the gap to be higher than the $28 million. It's $32 million. And that does this gap include CIP costs? So CIP cost is above this amount. Okay. So then your gap is much larger. The total cost, I know the retiring speaker had a lot of questions regarding that, but just to confirm, I know your greatest needs, obviously the electrical panel, the IT system, the EHR. When I drive by GMH, I see the hanging wires outside, and that's a cause of concern, huge cause of concern. So that to me is like, you need to get that done right away. So which leads me to the thought about cash flow. I know you guys you have priorities, keep the lights on, utilities, supplies. Maybe I know the cash flow, can you explain the cash flow? Or give us a picture of your cash flow. Do you have the full allotment? So let's say after every budget, do you guys get the full amount and then you have to partition that throughout the year?
No, the allotments come monthly. So we get the general fund appropriation usually towards the beginning of the month, and then the farm fund allotments come usually in 2 tranches maybe, because it depends on what the PPT collections are. And so although our appropriation is $2 million a month, we don't get the $2 million like in one batch. They'll calculate what BPT has been coming in, and then they'll give us usually half and then the other half towards the end of the month.
Do you think that should be adjusted so you guys can get the electrical wires taken care of? I mean, is there a way to work with BBMR to fix some of these problems so that it's not a hazard?
Senator, even if we did get BBMR or DOA rather to release the allotment, ultimately the budget is still short of what we need to make payroll. I'll give you an example. August is a 3 payday month, and so for most employees, they get excited about that. But for Yuka, I imagine she's a bit stressed out of having to meet 3 paydays in a month when our cash flow doesn't quite deliver on that.
Okay. So can you give me the total amount for your CIP projects?
$29.3 million was what we were requesting for FY26.
All right. So if you add the gap in operation, so that doesn't include CIP plus the 29, then we're talking 60 million.
Yes.
You need 60 million. Is that that's what you need right now for this year?
Yes.
Okay.
And that's it's a 28. Just to clarify, it's a $28 million shortfall on the operations side, and then a $29.3 million for CIP.
Because I'm calculating 32 gap because 40. We didn't give you what you asked for. It's actually short. It's 47 million versus So the gap is 32. If you can confirm that.
There were other provisions included. So like Chapter 1 includes a $1 million for funding the GMHA tax credit program. And then under Chapter 11, the miscellaneous appropriations, there was $5.2 million of excess 2023 collections that were also appropriated to GMH.
Okay, is OFB here? Hi, Vanessa. Can you confirm how much total in the budget that's appropriated to GMH?
For this current year or for the SBIL?
This current year, yeah.
For
So
this? Okay.
just if you can confirm what Mr. Kenga said.
Okay, what was appropriated in Public Law 37?
No, sorry, for this
for this,
upcoming,
okay.
Budget.
For
2026 budget.
For 2026, okay. So what we put in the substitute bill, we put 41.9 million, which is including the general fund and the pharmaceutical fund. And then we also put additional 5.2, which uses the surplus from the FY23 audit. So a total of 47.1.
But you're saying, Mr. Kenga, it's more than that?
We're saying that the gap is greater with the substitute bill with no amendments. Total difference just for operations is $28.2 million.
Okay. Because if you're subtracting, so basically collections, let's say it's 134 million, is that accurate today?
We're a little short,
Okay.
but that is the goal, to collect that, and we are working really hard with the payers, and our issue right now is denials. They are denying many, many claims, and I don't have enough people to keep on top of it, but we're trying to design a system where we can be on top of those denials and appeal them timely, so that will improve the cash collections. We also have been working with our Medicare adjustments to see when those will roll in, but those don't come in very quickly. CMS takes even up to a year to approve those, and then I don't even know how much they will approve. So we are short currently, and then with the downtime that we've had, the collections have been a little bit slower rolling in, but they are coming in. But our issue right now with the collections is really denials.
Okay, denials from insurance
From the insurance,
companies.
yes.
And what's the reason for their denials?
There are many, many, many
Reasons?
reasons. Yes, a lot of reasons. What we do with the denials is, whether they're warranted or not, we still have to appeal. So we do have to take the time to submit the appeal formally to the insurance company within a certain time period. So it does add an additional burden on the staff to have to deal with all the denials, even if they're not warranted and we don't agree with them, we still have to respond.
And sorry, just to add on to that, I've dealt with insurance companies both here and stateside. Guam health insurance companies have some, I say, Guam-only practices of how they do it. Most insurance companies don't require the submission of medical records at the time of the claim. They will request them for like auditing purposes, so you have to produce them upon request. In Guam, though, with all of the insurance companies, we actually have to go through and supply all of the medical records at the time of the claim, and so sometimes even denials or requests for more information may come back because something didn't get scanned right, you know, or the scan wasn't completely legible or something, and so that creates a really big administrative burden because we don't just have to produce the claim, we also have to go through and produce the entire file of the medical records, which is not a typical practice for most insurance companies stateside. They'll request those later on specific claims.
Okay, does that stay the clock? Because you know you're supposed to get it in by 90 days, or how many days?
Yes.
Does that hold the clock or suspend the clock?
We have the 90 days to bill, and then they have to respond to us within 30 days. Either if they're going to submit a denial, they have to let us know within 30 days, and then we have, I believe it's 45 days to appeal the denial.
Okay. So in looking at the audit, of the OPA audit, there are different categories of accounts receivable. So you have DRT referrals, self-pay Medicare, third-party payer Medicaid, collection agencies, and the MIP program. So which is the largest gap, and perhaps which is the one that you think we would potentially collect the most, I guess, the chances of collecting?
What chances of collecting are the best on
Yes.
those? It would be from the third-party payers and Medicare. Our most difficult is the self-pay. That's our most difficult to collect from.
Okay. And are we seeing trending in any of these categories as far as decreased collections, or are we stabilizing in any of these categories?
I feel we are stabilizing. Our issue with Medicare has always been just the low reimbursement rate, but of course Medicare processes our claims within 10 days. They actually pay very quickly. Medicaid is also pretty current, but of course they also pay us less than what we bill. And then with the third-party payers, of course, we're having the issues with the denials, but we're not ignoring or really delaying. We're very aware of the time frame that we have. That's the thing, that we don't want to lose any claims. If we have 90 days to bill, those claims have to be in 90 days. The self-pay has always been a challenge for us, and that continues to be a challenge for us. We're trying to get them all on Medicaid, but not all patients qualify for Medicaid, or sometimes the process to get them on Medicaid is pretty long, because they need a number of documents to submit along with their submission. So that becomes something that prolongs the claim. Sometimes we don't even get the the patients on Medicaid until after a year, and in that time, the claim has already, it's too old. We can't submit a claim after a year for Medicare and Medicaid. We have a year for that, and if it takes that long to get them on Medicaid, we lose the claim already. So that's another issue we have. But as far as collections with all the different types of payer buckets we have, again, it's the self-pay and then the denials we have from the third parties.
So yeah, we did pass a law that we're going to go through, I guess, a new system for Medicaid, I believe, to enroll patients. So hopefully that helps. That's through DPHSS.
That sounds wonderful.
Yeah,
Yes.
work with them on that one. Okay, so yeah, that's. I don't have too many other questions. I think a lot of the questions were asked in regards to revenue-generating opportunities, as well as, it's nice to hear that you're working on the grant as well to help kind of fill the gaps. But for now, you truly need 57 million, roughly, 57 million more than what we appropriated. And, okay. All right. I think I will wait for the second round if I have further questions. Thank you.
Thank you, Senator Perez. Senator Guåhan, you're recognized.
Thank you very much, Mr. Chairman. And good evening, panel. Thank you for being here on a Sunday evening. I'd like to actually thank Dr. Sabio for earlier saying that there's an immediate need for patients that come to GMH, and the continuous dock of a new hospital does not solve a patient's immediate need that come in there at this point. So that being said, I want to ask, and I think it's Ms. Garrido maybe at this point, because she was quoted, and I think it was 2024, in regards to the $15 million that, again, that was appropriated for the birthing center. The audited, $15 million audited fiscal 2023 surplus funds via Public Law 36-107. Is there any funding? It's still there. Your quote of the PDN back then that it was still there. Is it still there? Make sure. And is there a permitting issue that blocks that situation, the birthing center, from happening?
Oh, so just to confirm regarding the funding, I believe Ms. Lillian and Ms. Yuka had just recently met with Mr. Byrne from DOA to confirm, and yes, the 15 million is still there. So we're okay with that. So what's happening is, of that $15 million, again, recognizing, and earlier I mentioned how we've been trying to find other funding sources to help with our CIP, and so we are looking at part of that $15 million to help pay for some of these ARPA-related CIP projects that we have, in particular the roof and envelope, and then the remaining portion of that funding is to be used still for, I believe, for our MCH. The challenge that we had with the MCH, which I've said before, was that we did put out the IFB, however, we did not have any bidders. And so what we've done is we've kind of gone back to the drawing board to see how can we reduce the scope of that work for the MCH, which will hopefully make it more palatable for the potential bidders. Because that was in seeking some additional feedback from the bidders, the potential bidders, that was their comment, was the project was too big and they were not able to submit their bids. And so we're taking a look at that and recognizing that our funding source is limited, and so we're still also making sure that what we will put out as an IFB will be appropriate.
Okay, I'm kind of confused. The project was too big for bidders? I mean, for the birthing center? Too big?
Yes. Yes, and for whatever reason, and again, it could have been the timing too, because this was around Christmas time, and I believe some of the potential bidders that were looking at the project also have projects, military build-up type
the reason why I'm
projects.
confused, because if a birthing center is too big for a contractor, a new hospital will be impossible for a new contractor if just a birthing center is too big. I can't believe that for a second. I mean, your emergency room is fairly new. I mean, it's not that it's not as old as the other buildings, but they did that. There was no gripe about that being too big, and I've never heard any contractor say, "Man, that project's too big for us." I mean, maybe it's too big for a certain contractor, and it's too big for us to bid on it, but I can't see that all contractors, that this is way too big. I mean, we got Camp Bloss that's here, that's a lot bigger than the birthing center.
Yes.
And that no contract or a contractor, all contractors saying it's too big? Really?
Unfortunately,
I don't buy that at all.
I think the contractors that are capable of doing a project that size are otherwise occupied on much larger projects. But then for the ones that are not occupied on like the military projects or other large projects on island,
but that's
it's
your
too large for
assumption,
them.
right? That's your assumption, right? That's not something they put down and said it was too big for us because that's an assumption at this point. I mean, because there's money there.
Yeah,
Yeah,
so,
but
so-
anyway, okay.
But again, so we are just looking at it just to make sure, because recognizing that it is a hospital and, the needs on that is a little different than a typical building. So, but again, we're currently...
It's a critical need. It's a hospital.
Yes.
Yeah, I mean, we only have one birthing center, I mean, in Guam right now. Okay, so I would think it's a critical situation. And I don't buy that for a second. But anyway, that being said, the previous medical director, Dr. Naomi Rambo, when he was here with us in March of 2020, of this year, Dr. Rambo, I asked him the question basically regarding the feasibility, the urgent need, okay? As Dr. Eusebio was saying, the feasibility of maybe looking at the medical arts building that's up there in front of GRMC, that maybe look at a critical area, GMH, that really needs a new facility, like maybe the birthing center and whatever the medical director may say, and if it's feasible, that they can use that as a bridge for a critical area, while the situation of a new hospital is being built. As Dr. Eusebio said, we need to, patients that are coming in right now, you're not going to say, hey, well, maybe the next time you come in here, 10 years from now, we'll have a new hospital. I mean, they're needing it now. My understanding, because I've toured that facility and made that proposal to the administration, I said, it's not a permanent fix. And it's not going to move the whole hospital area, but what critical area can you use this as a bridge for, again, for the critical need of a hospital? I mean, because if that building was conducive for a school, believe me, school students would be there right now. But it was built for a medical facility, maybe not quite a hospital. Maybe it's going to take a month or a year maybe to get it ready, but and Dr. Naomi at the time said, we'll look into it, it's a good idea. It's a bridge. It's a facility that we can use to augment maybe the more critical component of GMH.
Senator, if I may comment,
Sure.
I believe that building was designed to be a clinic, not a
sure.
hospital.
Sure,
There's a big difference between a clinic and a hospital.
No, absolutely. And I spoke to the owner, and you're exactly right. It was built for a clinic, but he said it's already piped in for oxygen. They said they can outfit it depending on what the critical need may be. They can outfit it on what it. I mean, is there conversation going on? That's what I'm saying. Is there conversation going on? Because the owner said, we can. It might take us a year, might take us a year and a half to ready it, depending on what critical area may want to look at being housed there. That's what I'm saying. I mean, if there's no conversation going on, we can only assume at this point, I mean, like we're saying, the birthing center is too big for contractors. Well, if there's no conversation between the owner of that building and GMH and whether or not we can do this, we're still speculating at this point. Are there conversations going on with that, and whether or not we can use that? Anybody? I don't think so, right?
I have not been approached. I have not been called to the table.
Can I be the one to approach and get you guys together? I mean, if it's a matter of approach, I've approached them already. I sit in the health committee, and if it's a matter of getting you guys to talk, and then maybe we can rule it out, and there's no way we can do it or not. I can approach the owner and say, hey, can you please sit down and see what's feasible? So we can, and if it's not, then okay, we'll never talk about it again.
We're happy to talk with whoever can
Okay,
offer some solutions.
I'll call Cesar Cabot tomorrow.
Okay.
I'll call Cesar Cabot tomorrow.
We do have to be careful under the procurement law with
I'm
going out for it on an
talking about
unsolicited
procurement. I'm not talking about procurement. I'm talking about whether something is feasible or not. Just get it off the table if it's feasible or not.
But the ultimate lease of the space we would be governed by the procurement law on unsolicited offers, keeping records of these things, and so we just need to be careful that we're not going to commit.
I understand that, but I'm saying you have a critical need. You have a critical need. You have patients that need a facility. A new hospital is not going to happen in 5 years. It's not going to happen. And as Dr. Eusebio said, patients need to be looked at and healed and hospitalized. And that's what I'm saying. Yes, we have to be careful. Well, you got lives out there. That's what I'm saying. So I don't buy this crock. Talk to each other. Can we do it? The building is there. Talk to each other. My goodness.
If I may add, Senator, so let's just say hypothetically, and again, I'll go into the hypothetical.
I don't want to talk hypothetically. We have a building, you have a need, the people of Guam have a need. That's not a hypothetical thing. That's a fact.
Okay,
That's a fact.
Even at that, we would need to then look at leasing, and we're telling you now, we don't have money.
Well,
so we're
that's
need
what I'm
money
saying.
For that too.
Well, we need to talk. We need to talk. You don't have money. But you don't have money for that, but we're touting a new hospital. If we don't have money for a bridge, how the hell do we have money for a gigantic hospital? Really? Come on. We're talking about putting a $1 billion hospital, but there's money for that. But a bridge that we need, we don't have money. Really? Really? Come on. I'm done. Thank you.
Thank you, Majority Leader Lujan. Ranking Member Tuno Rose, when you're recognized.
Sizu Smasi, Mr. Chair, and to the panel members up there, thank you for being here with us this evening. I'm going to try and make it as short as possible. I know it's almost 8 o'clock, but in the efforts, I know this was tapped on a little bit earlier as it relates to the travel nurses, and I just want to touch a little bit more into it. So how much has the Guam Memorial Hospital spent on travel nurses so far this year? And then how much are you projected to spend by the end of this fiscal year?
Right now, we owe them $4 million as far as from this year.
From this year?
Going back to
October last year to present.
So you have not paid, Ms. Lillian, the travel nurses right now?
We have been paying, but small, payment plan, we agreed and they agreed. They accepted our payment plan of $150,000 every 2 weeks. But even with that, we haven't been able to meet that payment plan every 2 weeks.
So that's from October to this month?
Yes, ma'am.
And then between now and the end of the fiscal year, which is next month, how much is that? Is that a total 4 million?
The 4 million is as of today. The weekly invoices that come from the travel nurse company is around $65,000 now a month. And we have, like Ms. Lillian reported earlier, we're down to 12, and they're ranging between, I think, $95 an hour.
Okay, so, and then how does that compare to fiscal year 2024? Did we pay more last fiscal year 2024?
We had more nurses that we hired from them, and the rate was upwards of 100, up to 115 an hour. So this year the rates are much lower, and we're also, we have much less nurses than we did the year before.
And then how much will you guys be estimating that you will spend on travel nurses for next fiscal year, for fiscal year 2026?
We have about a $4 million budget for nurses next year.
And I know you also tapped on it a little bit in, as far as the actions of the local nurses. So what actions are being taken to recruit more local nurses so that we can reduce the money spent on much more expensive travel nurses, and the comparison there? How much are we paying the nurses, the entry nurses that are coming in after they complete their programming with the university?
We're bringing them on board as an above step, and rather than starting them at step 1, I believe we're starting them at step 3.
At step what?
Step 3 on the nurse
Step
pay plan.
3.
Correct, Senator. And then we also had the Board of Trustees adopt earlier this year the Graduate Nurse Recruitment Incentive Program. So that provides them with a stipend. The first amount would be distributed upon completion of their probationary period, and then the second release would be afforded to them after completing 2 years of service with GMHA.
So based on the recruitment there, have we been able to keep, are we losing any of the local nurses that we pick up today at the hospital going to other alternatives out there?
If we can fund these positions, you give us a fighting chance to recruit these nurses. I wish that Christine was here, our nursing director, because she would really expel this story of just how great UOG graduates are from the nursing program. Like, they're cream of the crop, and they really do amazing work at GMHA. The challenge is, I mean, we have 3 right now that we're trying to run through the pipeline. We'd love to recruit all of them, but the budget doesn't give us that reality. We're hopeful that we can make other concessions in order to recruit those talented nurses.
Thank you. Thank you very much for that, Mr. King. I'm going to shift gears here. What percent of your staff handles direct medical care versus those that are strictly administrative in nature?
So if you look at the totality of our workforce, I mean, we have 1,285 across 3 facilities. We have 80% that are clinical, 20% that are non-clinical, but do factor in that other positions that are just as important in the non-clinical are not just administrative staff like your admin assistants or your program coordinators, but can be your environmental services, your biotech, your FM, the folks that replace the light bulbs or come out and adjust the fire alarm or sprinkler system. So 20% make up the non-clinical positions in those areas just described to you, while 80% are clinical positions.
So let me add on to that. Do you feel that this is the correct ratio of medical and administrative staff, or do you have plans to align this to be better balanced?
You'll find that from our vacancy pool, we have mostly clinical positions that remain vacant. And so you'll probably see that ratio grow more on the clinical side if we're able to fill those positions subject to availability of funds. So really the ratio should be greater on the clinical side, but because of our inability either to find the capable or talented credentialed staff in the clinical field or the availability of funds have us deferring recruitment so that we can either make payroll for existing expenses or pay for vendors.
Thank you for that. And I'm going to try one more, Mr. Speaker. Given, and this is not going to be an easy one, given the recent incidents reported during the legislative hearings, including a hurt person being found at your guard shack and then a death investigation involving a person falling inside the hospital facility, my question is, what actions has the hospital taken this year, and what plans are you seeking to fund next year to improve the safety and security of our public hospital? Anybody?
Some of the things that we've done is we've done walkthroughs throughout the hospital to see if there's any areas that we can identify that need to be further secured. We've also worked with our security team to continue to make their rounds periodically throughout the day to ensure that, there's nobody that needs, so that they don't find anyone that, would need assistance. And if there is, then of course to make sure that we take the proper steps to ensure that they get the assistance needed. We've also worked at, together with our compliance and our safety office to, again, ensure that areas that would need to be secured, if they're identifying if they're egress or ingress, and making sure that all of those are all addressed.
Are you doing any training programs to that? Jordan, did you want to add anything?
Yeah, I was just going to add on to that. We do also have a full-time risk manager whose part of their duties are to do after-action evaluations of these things and investigations of incidents. I wish I could tell you more about the specific incidents that were reported on, but we can't because of patient information and other things, because I would actually like to compliment some of the staff members that were involved in our incidents. But we do go through that, and there is a patient safety work product process that we have where anybody can submit through a safety learning system, an SLS, which is anything concerning patient safety or issues in the hospital that may relate to safety, and then we can address. They get scored on levels of seriousness, and then we address them. All of these things have been addressed through that as well, which includes some retraining as well as policy updates and working with the various departments that may have been involved in the incidents.
Thank you for that, Jordan. Mr. Speaker, I bring a lot of these questions up as we look at the mandate of the hospital. You and I know that, or our colleagues should know that the hospital continues to have a mandate that no matter what happens, they have to accept every patient that comes in, and no matter how much we give, it probably would never be enough because we can't turn anybody away. And my greatest wish for them is to make sure that we have a dedicated funding source, and may that sound or look easy to do. It's not. And again, we can keep giving and giving and giving because that is the mandate of providing for our community, is to make sure that we take care of the health, safety, and education of our community. And hopefully one day soon, Mr. Speaker, that there will be a dedicated funding source. I know that the hospital gets the payments, and I think maybe if we look through automation, if we look through better collection services, if we look through the latest trends on proper patient information that can be kept instead of having a lot of manual inputs put in, then things can get better. And I say this because my mom, having grown up in the hospital, really from the old hospital, and you and I know that, Mr. Speaker, since we were in Mercy Heights. But I always remember my mom saying that even when she was the PIO, when she was the chair, we will always be that political football unless there's a dedicated funding source to give to the hospital, even if they have fee-generating programs, because we cannot refuse any patient that walks through our doors, whether they're insured, whether they're self-pay, just real, even our traveling visitors, we can't turn anybody away. So I will continue to work closely with the Oversight Chair and hoping our colleagues can work with that too, because this is very important, and this is...
Senator, if I may add that one of the things that I think that the legislature can do is put some teeth in the Prompt Payment Act. We have a law that the insurances are required to follow, but it's a game. And it's constantly causing us a lot of consternation, not only the hospital, but also the private physicians that are out there in clinics trying to make collections, and these insurance companies playing this game of, why don't you resubmit the forms, resubmit your bills again, even after you've submitted it, we didn't get it. Resubmit it again, so that they can fall again into that 90-day time period. It's a game.
Doc, thank you very much for that insight. Yes, most definitely that could be revisited. I remember the days of Matt Lonak and all that, where payment was difficult. If payment was difficult, there was garnishments, but there was also an aggressive move to get payment back from the insurance companies. And there is, our billing system has to be upgraded too, and the software system. So there are a lot of work that still needs to be done, but I know that I see you guys as key players up there. I think that we can literally journey this process forward. And I duly noted on the recommendations you talked about, and I will ask the Oversight Chair if we can continue to work on that closely together and see what we can do.
Thank you,
she's nodding
Senator.
her head.
And
So
Speaker-
thank you, Mr. Speaker. I know my time is so almost up, so I'll yield the rest back to you.
If I may add, Senator and Speaker,
You can proceed.
we also have that population of self-pay patients who are really social cases. And so these are individuals who have been in the hospital for years. And so that bill alone, it's about 50 million. That we're
50
not-
or 15?
50, that we're never going to get reimbursed for.
Yeah.
And that's why we look to this legislative leadership to help us get the funding for that. Thank you.
Situs Masi, and thank you for bringing up again. Thank you, Mr. Speaker. I yield back.
Thank you very much. Ma'am, you done? Okay. Mr. Vice Speaker, you have the floor.
Thank you, Mr. Speaker, Mr. Chair. Probably just a couple of questions for the panel, and thank you again for being here. I know that it's already 8 o'clock. So I just had maybe a couple of questions on we're looking at different types of funding. Did you guys apply for and hear back anything from the Community Development Block Grant Disaster Relief Fund?
Yes, Senator. We submitted our comments as we reported before, and my understanding is that the application process is not until January. We have been monitoring their website to see if there's any new updates, but that's the latest we have. But we did submit our comments. We made sure that our input has been provided regarding the CDBG DR.
And how much did you request for?
I believe we put everything in there, so.
I know we put everything in there, but what was the ask?
The actual ask will be in January when the applications open. At this point, we have put in the whole list of everything that we're asking for into the comments to demonstrate what the total need is. And so, Rodolin, and that's the 29 point, or
well,
what did you put in the report?
I believe the $20 million related to the electronic distribution panel or the electrical distribution panels in there. We did make mention of all our IT needs, and yeah, to say the least, but they're all in there.
Okay. And, earlier, a couple of months ago, you had a visitor from Health and Human Services. Do you recall that visit with Mr. Gonzalez?
Health and Humans, no, we haven't gotten a visit from HHS, but we've been in communication. We had someone who was the acting regional director, Mr. Dennis Gonzalez,
Yes.
from Region 2, I believe. Right, and so we spoke with them about this HR Bill 1928. We talked to them about many other, funding issues that we need help with. And so that was the visit that we had sometime around June, I believe.
June 26th, to be exact.
Right, June 26th, correct. You're right.
Yeah, definitely, because I met with them as well. And June 26th was a very wet day. And he happened to go to the hospital during his visit and saw blankets and towels on the floors. And he was really taken back by that and asking and wanting to do everything he can to help the hospital. So from June 26th to this day, what conversations have been had with Mr. Gonzalez in trying to get funding for Guam Memorial Hospital? Because before he left here, he told me, Senator, you guys build a new hospital, that's up to you. You buy a current hospital, that's up to you. Where you guys place it, that's totally up to you guys. I'm here to help stabilize what you have now.
I emailed him, and I haven't gotten a response. I emailed him twice to follow up. I haven't gotten a response from him.
All right, so I can follow up with a phone call with him. When did you email him? What days did you email him?
Probably about 2 weeks ago or 3 weeks ago, I emailed him. But prior to that, I also emailed him immediately after he visited us.
Okay.
So did I.
But I'll call him.
So did I. I also emailed him, but I have not received any feedback.
And when was your email to Mr. Gonzalez?
I believe it was shortly after his visit,
Okay.
but I can get that to you.
All right, thank you. And, I also heard, many other things this evening. Dr. Eusebio, I totally understand about the Prompt Payment Act. But, it goes both ways, right? We expect payment from the insurance companies, but our vendors also expect payment from the hospital, right? I mean, and if we're gonna, are any of the insurance companies behind in their payments?
The answer is yes. And we're actually having a specific issue with one of the insurance companies' interpretation of the Prompt Payment Act, where they don't even think they have to give us a response within 30 days of receiving our claim anymore, denial or otherwise, and that they can sort of deny at any time after receiving a claim. And so we're having, we're even having trouble just getting, denials at this point even. They're just delaying.
Have you worked with the oversight chair in trying to perhaps come up with legislation to refine the Prompt Payment Act and what we need to do to,
Yes,
get
I've had a couple conversations with Senator Montanani. We've been collaborating on some ideas for it, and been getting some input from Dr. Eusebio and the fiscal team, because we've also been going back and forth and writing with some of the insurance companies over their payments and practices. And so once we get a mechanism with some more teeth, we will work with Senator Montanani to get that introduced.
That's great to hear, because that's what we need to know, right? And that way, the laws back then perhaps were doing what it needed to do then, but just like everything else, it needs to be refined, it needs to be updated. There's different ways of doing things now, so any way that we can help facilitate the payments to Guam Memorial Hospital so that in turn you guys can facilitate the payments out to the vendors. And it's a two-way street, right? So anything that we help, and I believe that we'll be able to go down that road once these things are in place.
And that's one of my personal frustrations in getting prompt payment from payers, is because it puts us behind with our vendors. If we would get more timely payments and then we could actually get some of the invoices out, it's never going to be a perfect system, but it just, the further behind we get, the harder it gets to actually catch up with it. And if we don't have the cash from the payers, we can't pass that on to the vendors either.
I mean, $60 million in 90 days, that's a lot behind, isn't it? So, these are the things that we need to address so that we can be able to pay these vendors. I mean, I don't know how much longer a vendor who is owed $300,000 and only paid $50,000 can survive, because they too have to pay their employees, they have to pay their suppliers that they get their products from. And, unlike government, right? The private companies get penalized for not paying their taxes or not even paying their bills. So we need to do what we can to ensure that the flow of cash is coming into the Guam Memorial Hospital. And it's these type of things that I wish we learned earlier, right? I mean, if the Prompt Payment Act wasn't working years ago, then, it should have been brought up and action should have been taken maybe 4 or 5 years ago, 2 years ago, instead of hearing it now. But if it was brought up before, then let's keep on it so that we can update it and work with it. But other than that, I don't have any other questions. You guys have been very straightforward of what has to be done, what needs to be done, and that's all we can do is just try to make it work and help you guys. Thank you, Mr. Speaker. That's the only questions I had.
Thank you, Mr. Vice Speaker. Gentlelady from Magaʹhågan, ma'am, you are recognized.
Good evening. Thank you, Mr. Speaker. Good evening to the panel. Thank you for being here despite the lateness of the evening. And thank you for being a trooper answering all these questions. I don't have a lot, but I do want to focus on this. Not the staffing, but we always have a challenge with our medical, I would say staff, right? Back in the day, before GRMC was built, there was a notion that we were going to explore the option of hiring nurses and doctors from the Philippines. And it's such a great idea that will actually save so much for Guam, for our government. So I want to bring back the focus to this notion, because it's something that we should push forward and explore once again, because I believe that the discussion just fell apart and it has been forgotten. Right? So on international recruitment strategy, I just wanted to focus on that notion. Guam continues to face persistent shortages in nursing and allied health personnel, while the Philippines remains a leading global source of English-speaking medical professionals. So my question is GMHA actively exploring recruitment partnerships or credentialing pathways to onboard qualified medical staff from the Philippines or other places?
Yes, Senator, I can answer that question. As a matter of fact, I just had a discussion with the governor Friday regarding this issue, and she is helping, will be sending to the legislature a law that will mirror a law in California whereby a international physician will be able to practice in Guam, and this was also discussed by the Guam Medical Board. Everybody is on board in terms of trying to get this thing done. I've been in communication with the president of St. Luke's, who has already given me the names of 6 physicians willing to come to Guam. And he's asked me for a timeline whereby this can happen. When I spoke to the governor, she said, because I told her that I couldn't give him a timeline because because there was no law yet.
Yeah.
And she said, tell him by December. And so hopefully between now and December, we can get something done, and that these physicians can come over and we can have them working at GMH, and specifically only at GMH. It's going to be a limited licensure law whereby they come and practice in Guam, but only be allowed to practice at GMH.
GMH alone. This was really help. And actually, for a long time now, in the last couple of years, the morale of our local nurses has been challenged. So I think this particular setup would actually alleviate that concern, right?
Sorry, I wish Christine Takero was here too, our nursing admin, because she's been working hard on trying to find some partnerships with recruiting agencies and other things in the Philippines to identify nurses there that may already have green cards or have passed the NCLEX and can actually start the process of hiring them at GMH. And she's actually, in the last year and a half, put in a lot of work to those efforts. We'll see the fruits of those in the next year or two, but she has put a lot of work into those efforts.
So this program particularly is looking for individuals with already green card holders, not Filipino citizens that we will probably help get temporary visas.
She's exploring both options, but there is one that she's exploring that helps identify individuals that already passed the immigration status and may have green cards or other forms of legal work authorization, as well as their NCLEX. And then she's also working on some other efforts to help identify how to get nurses who do have their NCLEX potentially over here as well. So it's not just one relationship that she's working on. She's actually working on multiple ones. The fastest one is for individuals that already have work authorization or green cards.
Thank you. Now, what safeguards will GMHA implement to ensure ethical recruitment and long-term retention of overseas hires?
May I clarify that question? Overseas hire meaning? Individuals from foreign countries?
Yes, or off-island, bringing them over here to work on Guam.
Well, for off-island hires coming from the States who are U.S. citizens, that's really not a problem at all, because we do recruit them without any difficulty as long as they are NCLEX licensed. It's the foreign graduate nurses. Although they may have the NCLEX, they pass the NCLEX and they have that U.S. license, immigration is our biggest hurdle. Because not only do they need to have that H-1B visa, but in order for us to hire them, we hire them at the prevailing wage, which is about $40 per hour. And that's just going to create more disparity amongst the nurses who we hire, and we're not able to offer them that $40 per hour. So that's one of our biggest challenges. I was in the Philippines many years ago, and we recruited nurses. Out of the 200 individuals that we interviewed, we were able to successfully bring in about 14 to 15 nurses. To this day.
40, ma'am?
What was that?
40 to 50?
I can't remember when I was, that was many years ago when I was working as a nursing administrator. And, we interviewed about 200 applicants, but unfortunately we were only able to get 14 or 15 of them to come to GMH. Of those 14 or 15, I think only 1 or 2 have remained in Guam. Many of them have gone on to the States. So it's a costly, adventure, but definitely something that we continue to explore. Thank you.
Thank you. I don't really have a lot of questions, but that is something that I'm really curious about because that will truly help our medical industry if we can bring in medical people from the Philippines. So on that note, I guess moving forward, we just need to streamline credential recognition, the process, and I would love to be updated on the status of all the, coordination, negotiation in terms of that. And being a Filipina, I could probably also assist. So on that note, Mr. Speaker, I thank you for the time that you've allocated, and thank you to the panel. And I have a lot of coffee upstairs if you guys need.
Thank you very much, ma'am. I hope that mine's empty. Gentlelady from Tamuning, Senator Taitigui, ma'am, you're recognized.
Thank you, Mr. Chair and Mr. Speaker, for the opportunity. I'm holding you from not getting to your pillow in time right now because I'm the last one, I think. But anyways, I greatly appreciate you being here. And throughout the years of dealing with GMH and all the issues that you have, I mean, the biggest thing is you're an agency that basically is financially unstable and have infrastructure that are deteriorating faster than anything else, especially on the climate on Guam, the issues that you deal with constantly. So it's very difficult. You're trying very hard, and I understand the concerns you have. Now, since we're already talking, that good Senator from Magaʹhågan mentioned, and Dr. Eusebio, there is a law that allows for foreign doctors to work on Guam, already in place. In fact, I was working with the Oversight Chair on Health, or not working with her, but asking her if she'd be interested in creating legislation with me to allow these foreign doctors. And through our research, we found out, or I found out, that it's already given the authority to have foreign doctors, like most states have that same ability. The problem is the medical board is not allowing them to come in here to work. So you have the medical board has the authority to allow these doctors to come in from foreign countries, but they're not letting them do it. Makes you wonder why.
I'm not aware of that law. I know that the medical board has discussed the desire to do this. This was something that if I would have been aware of it when I was the chairman of the licensure board, I certainly would have done it. But I'm not aware of this law that exists right now. The medical board discussed this last month and trying to do something of that nature, is trying to write something up so that they can allow this to happen. I know that there's several states that have this law that allows it to happen. I'm just not aware that it's possible in Guam.
Yeah, it is. It's on Guam. It's in law. But the problem that we're having here is that the board is not allowing these doctors to come in. I don't know why. Maybe it's because they don't want to share. And their clients might go to somebody else and keeping clients with themselves, whatever the case may be. I've already drafted legislation to try and correct some of those issues and to allow this to actually happen if they comply with certain requirements, that they'll get in, regardless of course, if they have any pending medical malpractice or things like that, that could stop them, of course. But I hope to move. I hope the governor is serious about it, and I'm going to introduce legislation on it very shortly here. So just wanted to bring that up. And if you want, Dr. Eusebio, yes, you can look at the Guam Medical Board's
what is
laws.
the law number?
Yeah, I have. In fact, I'll share it with you. I'll try and hurry so you can get home and research it. Because I'll go ahead and finish, and I'll show you the law, okay? Moving forward, they talked about vendor payables, and I just wanted to know, what was that number that you gave in total vendor payables that you need to pay off, all of it? I mean, 60 days, 30 days? What is the amount now that you have?
25.6 million.
Okay, to pay everyone off, right? Okay.
But that number moves.
Oh, yes.
Every day.
Every day.
Every day.
But right now, in the books, it's 25.6 million, correct? Okay, in the books right now. What is your current nurses to ratio normally? Patient, I'm sorry, your current nurses to patient ratio. Yeah, I did say that, right? I'm getting tired.
Yes, it's the
normally.
nurse-patient ratio.
Yeah, yeah.
And it
What is
varies
that?
in the areas, in which areas, like for ICU, it's primarily 1-to-1, one nurse to one patient. Depending on their level of care, it could be 2 nurses to one patient.
Yeah, but that's an emergency. What about,
No, that's
just
in
the
the
other
ICU.
floor? Oh, the
That's in the
ICU?
ICU.
Oh, yeah, the ICU,
In the
understandable.
telemetry unit, it'd be 1-to-4. When I used to work in the telemetry, I would get 8 patients, and that was quite a bit of a workload.
Wow.
So we're trying to maintain 1-to-4, 1-to-5 at the maximum.
But right now, what is it then? It's 1-to-8?
No, it's not 1-to-8. That was when I was practicing.
Okay.
So we're trying to keep it at 1-to-4 or 1-to-5.
And it is at 1-to-4? I know you want to keep it there, but is it there now?
Depending on, again, on the staffing availability.
Yeah, I
and
understand.
the
But
level
normally,
of-
normally though, the average.
1-to-4, 1-5 actually
Okay,
the average.
1-to-5?
Yes, and then in
Okay.
the surgical and med-surgical area, depending on the criticality of the patient, it's 1-to-6, the
And-
ratio.
And what extent are these issues, impacting the patient care at Guam Memorial? Not having enough nurses. We were always talking about not having enough nurses, or how's that affected the patient care at Guam Memorial Hospital?
Well, because they work as a team, they have nurses aid, they have cardiac monitor technicians, and in the emergency room, they have ER techs. They work as a team, but again, the full responsibility is on that RN, managing the full care of that patient, but we augment them with the support staff.
How's the elevator situation over at Guam Memorial Hospital right now, the elevators? Because I know you had some problems with the elevators, so I guess I can talk to maintenance on this part. What was the status on those elevators?
Right now, all 4 elevators are working.
Oh, that's
We
good
are
news.
under Otis.
That's good
It's under
news.
contract.
That's
Well, we
right.
kind of get some of those problems once in a while, but they are still responding to our calls.
Yeah, that's the biggest problem. You get it fixed, and the next thing you know, in 2 months, it's broken again, and trying to get them out there right away. Because are you using Otis or which?
Otis.
Yeah, and they're not on island, so you have to make a call to have them come out to do kind of repairs. So hopefully they are on island, but they're not always available here. I mean, I think he does all around the Pacific. But
Yeah, they have a lot of other elevators to service
Oh, yeah.
all around the
Not
island.
just on Guam, though. That's my concern. So, but I'm glad all 4 are working. That's good news.
Yes, ma'am.
Really good news. Procurement issues. You had a OPA report with the hospital, and meeting the guidelines of having individuals take the modules, procurement modules. Can you tell me on an accounting side how many have taken these modules, 1-to-4, over at Guam Memorial? Because during the OPA report, they talked about the deficiencies at Guam Memorial Hospital and the procurement process in complying with the Guam procurement law and its procurement regulations. So our good senator from Magaʹhågan, Senator Paris, who introduced legislation to ensure that anyone who's dealing with funding and money, that they take these procurement classes. So how far are you on getting everyone on board with these procurement classes? Yeah, go ahead. Okay, please.
So I believe our materials management has been tracking this, and so my understanding is right now they're in the process of compiling to see, get everybody who has completed their courses. And also in the law, I believe the minimum that they're required to take is Module 1.
Just Module 1,
Yes,
right?
and then for the rest of it, depending on your level, then, you would take the other courses.
And are you up to date on that?
For myself, yes, I'm done with all 4.
What about other people who deal with procurement?
Yes, I believe for we're we're trying to make sure that everyone is, but as far as I know, the key people that need to know, and particularly the ones in our materials management,
Yes.
they all have Module 1.
Okay, but I've attended Module 1 myself. I decided to just find out what, these classes are and attended. I did Module 1, but it really doesn't say very much about procurement and how to handle it. Now, Module 2, Module 3, these get really down to the nitty-gritty of how to deal with procurement. So how many people who you oversee as procurement that are under you, who are working under you, have taken Module 2 or Module 3?
As far as from materials management, I believe the the materials management administrator, the assistant administrator, as well as the supervisor are, I want to say they're complete with all 4.
I hope so, because it's not just us giving you money all the time, and throwing it your way. But if you do not get these procurement through in the correct manner, then there's a delay and a delay and a delay, and things are set back. So I really ask Lillian that, to make sure everyone has their modules. And regardless if they're only taking one, they should really take all 4 modules if they can to move forward. Also in the OPA report too, it mentions the contractor for RCM. What's the status with this particular contract?
Senator, that contract's over.
Okay.
We ended it.
So it's done, right? Okay.
Yeah,
Okay,
it's
no problem.
done.
Just wanted to find out if there's anything up there. So other than that, I hope they're going to let you go home now and take a rest. But I greatly appreciate your time, your effort, and your advocacy, because, I remember the days when we used to ask you to ask for more money because you needed it, but you stayed within a certain, guideline, and we all knew you needed more. So today you're here advocating for that, and I appreciate it. So thank you so much. Be safe, and please, to all the employees at GMH, give them our very best, and that we appreciate what they do every day for our people. Thank you, Mr. Chair.
Thank you very much. Colleagues in panel, that completes round 1. Okay, so in the interest of it for everybody, I'm going to modify round 2. And I'm just going to basically ask, does anybody have any questions that they want to continuation? I'll give you the 5 minutes. But if nobody wants to talk, then. Well, I'm going to ask if you have anything right now, because if we can get it out of the way now, we can get it out of the way now. Do you want to do it that way?
Yeah, I would prefer to ask the questions tomorrow.
I'm going to still run it the same way tomorrow. Okay? It's up to colleagues.
Can you repeat that, Mr. Speaker? I can't understand.
I am not going to. I am going to go to the senator that has a question, who wants to ask a question for round 2. I'm not just going to go.
But I do have questions, but I can wait till tomorrow
Okay.
to allow the panel
All
to
right.
get some rest.
If that
but
be the
anybody
consensus of the group, then that's okay. So we're going to be 8:30 tomorrow. We're going to continue this. So we're going to be in recess until 8:30 tomorrow morning to continue round 2, but in a modified version where only the senators that have the questions will be able to ask. Okay? So we're in recess until 8:30 tomorrow morning.